the Department of General Surgery of MES, AMS and Malappuram Surgical Society under the banner of ASI Kerala Chapter, we take great pleasure in welcoming you all to the much awaited annual PG CME of 2023. Though it's a little cloudy and rainy outside, we expect a good full jam-packed session. This is day one and the academic schedule looks very promising and very innovative. Just waiting on clearing some technical details, and in the meanwhile we'd like to tell you that we are going as per schedule, maybe a couple of minutes up and down. The first case presentation will be on thyrotoxicosis. May I request the delegates sitting in the hall to kindly take their seats towards the front of the hall, please, as a mark of respect to the speakers. Once again, request to put your phones on silent or vibrate mode. Move into the first case presentation, and may I invite onto the dais the examiners, Dr. Sunil S., Dr. T.V. Haridas, Dr. Rajit, and the chairperson, Dr. Maharajan, will be joining us shortly. The first case presentation will be made by Dr. Alan Joseph and Dr. Alan Nair. May I hand over the proceedings now to our esteemed examiners. Over to you, sir.
Good morning, respected teachers. So today we will be presenting a case on thyrotoxicosis. So this is about Soumya, a 20-year-old female patient. She is hailing from Kuttanallur, Thrissur. She is doing her BSc and is 20 years old. Her chief complaints are swelling in the front of neck for the last 6 months, loss of weight for the last 4 months, and shortness of breath for 1 month. Coming to history of presenting complaint, the patient was apparently normal 6 months back. After that, she developed diffuse enlargement in the front of neck, which was insidious in onset and gradually progressive. There was no associated pain in the neck. She also complained of weight loss of around 10 kilos in spite of increase in appetite. She also complained of diarrhea. Also, complaints of shortness of breath on exertion for the last 1 month and was associated with easy fatigability. She is apparently irritable and says she is intolerant to hot weather with excessive sweating and prefers cold weather. She also complains of disturbed sleep and lack of concentration. Also, her relatives have noticed bulging of eyes since the last 1 month. There was no history of fever, no history of weight gain, constipation, bradycardia, no history of menorrhagia, cold intolerance, no history of difficulty in breathing, no history of hoarseness of voice, hemoptysis, no history of difficulty in swallowing, no history of bone pain, jaundice, anorexia or hemoptysis. Coming to the past history, there is no history of radiation therapy to head and neck region, and she does not have diabetes, hypertension, epilepsy or bronchial asthma. Coming to menstrual history, she attained menarche at the age of 13 years, a 30-day cycle of which 2 days flow is there, and she uses 1 pad per day. Dysmenorrhea was present and no passage of clots was seen. Coming to family history, there is no family history of thyroid disease in the family or locality. There is no history of malignancy in the family. Coming to personal history, she follows a predominantly non-vegetarian diet. Appetite is increased, sleep is decreased. Coming to bowel and bladder habits, it is more diarrhea predominant, around 3 to 4 times a day, and bladder is normal and regular. No habit of substance abuse. Coming to treatment history, medical history, there is use of over-the-counter antacids and analgesic use, no history of thyroid medication, no history of contraceptive use, and there is no relevant surgical history in the past. Summarizing, so this is a 20-year-old girl presenting with a diffuse swelling in the front of neck since 6 months, which has increased to double its size since the last 1 month with associated weight loss, palpitation and irritability. She is also heat intolerant and sweats excessively. There is no feature history of hypothyroidism and malignancy.
So coming to general examination, the patient is made to sit in a well-lighted room and informed consent was taken for examination. So here there is a 16-year-old girl who is agitated and nervous but oriented in time, place and person. The patient is thinly built. Coming to nourishment, the BMI was about 19 kilogram per meter square, but There was no overt signs of nutritional deficiency. Clubbing was present. There was no pallor, icterus, cyanosis, lymphadenopathy and edema. On examining the vitals, respiratory rate was 18 per minute, regular rhythm, bilateral symmetrical, thoracoabdominal type, and on examining the pulse on the right radial artery, it was about 110 beats per minute, regular in rhythm, normal in volume and character, condition of arterial wall normal, other peripheral pulses were palpable and bilaterally symmetrical, blood pressure 130 over 80 millimeter mercury in right arm in supine position, the temperature was 98 degree Fahrenheit measured in right axilla. Then on examining the hair, it was black, lustrous and was sparse. Skin was dry and coarse, and we noticed excessive sweating in the palms. Spine was normal. On examination of the limbs, in the upper limb there was fine tremors over the fingers. Lower limb there was whitish shiny plaques over the skin over the tibia. There was no proximal muscle weakness. Then on coming to local examination, on inspection, there is a diffuse 5x4 swelling in front of the neck measuring about 5 centimeters horizontally and 7 centimeters vertically, extending longitudinally from thyroid cartilage to about 5 centimeters above the suprasternal notch and horizontally between the anterior borders of sternocleidomastoid mastoid muscle on either sides. The surface here appears to be smooth. The overlying skin appears normal. It moves up with deglutition. The lower border is clearly visible. It does not move on protrusion of tongue. There was no scars, sinuses or engorged veins. The trachea appears to be central. So on looking for the eye signs, bulging of both eye signs were present with staring look, Stellwag sign. Then Joffre sign was positive, Nafziger sign was positive, lid retraction was present, lid lax or bone graphy sign was positive, dire limb sign positive, Mobius sign was present. Then palpation, the inspectory findings were confirmed on palpation, and there was no local rise in temperature and there was no tenderness. The trachea is central. The surface is smooth and firm in consistency. Mobility, it was mobile in horizontal plane and not in vertical plane. We were able to get below the swelling and the carotids were felt in normal position. And on Lahey's method of palpation, margins of both lateral lobes were felt. And on percussion, it was resonant when percussed over the manubrium sterni. On auscultation, a systolic bruit was audible near the upper pole of the thyroid lobes. And on examining the lymph nodes, there were no enlargement of the cervical lymph nodes. On systemic examination, cardiovascular system, S1, S2 were heard, no murmurs were heard, no additional sounds were heard. On examining the respiratory system, normal vesicular breath sounds were heard, equal bilateral air entry, no added sounds. On examining the abdomen, it was soft and there was no tenderness, there was no mass or no organomegaly, bowel sounds were heard, and central nervous system was also found to be within normal limits. So, summary, it was a 20-year-old girl who presented with diffuse swelling in front of the neck since 6 months, and which was increased to double in size since 1 month and was associated with weight loss, palpitation, irritability. She is also heat intolerant and sweat excessively. There was no feature suggestive of hypothyroidism and malignancy. On examination, the patient was restless, has tachycardia and eye signs suggestive of thyrotoxicosis. On local examination, there is a bilobe swelling in front of the neck in the midline, smooth surface and firm consistency, moving in deglutition with palpable thrill and audible bruit. The provisional diagnosis is primary hyperthyroidism with thyrotoxicosis, Graves' disease.
How old is that patient?
Sir, 20, sir. That was.
There is a mistake.
There was a mistake, sir.
Because in general examination you said 16 years.
Sir, 20, sir.
Why did you ask for a history of fever?
Sir, it's a swelling in front of the neck, sir. So it can be due to tuberculosis also. So then thyroiditis.
Thyroiditis, you get fever?
No.
So lymph nodes occur on the lateral side of the neck, no?
Yes.
So nobody says front of neck, on the side of the neck. So unnecessary questions can be avoided.
Yes.
Right. So young patient, there is no history of thyroid swelling before. It is just noticed along with this complaints of weight loss.
Yes.
Everything came together. Yeah. How many kgs weight loss?
Sir, 10 kilos. 10 kilos.
Right. Another thing is,
Sir.
thyroiditis?
Sir, sub.
Hmm? What are the types of thyroiditis? You know,
Acute, subacute, and chronic.
Is it very common in thyroid?
Uh,
How often you see it?
so could be seen usually in very young patients.
Is it very common or
No.
Why? Because neck is a common area where you get all but acute suppurative thyroiditis is very, very uncommon. What are the reasons? Probable reasons. There are some reasons given in the books. Because the one is a thick capsule. Thyroid has a thick capsule. Second is good vascularity. Third, what does it contain? What is the active ingredient of thyroid hormone?
Thyrosin.
Iodine. You use for cleaning, is it antiseptic? These are the reasons why you don't get acute suppurative thyroiditis very often. Okay. Other type of thyroiditis, you may get mild fever, like recurrent thyroiditis, then you get mild fever. So it's not very common and don't say lymph node in front of the neck. In our locality, there's only one diagnosed thyroid. Don't say they are tuberculosis and all.
Which is the commonest form of thyroiditis?
Subacute thyroid.
Subacute.
Hashimoto's.
Hashimoto's. What is Hashimoto's thyroiditis?
Chronic lymphocytic thyroiditis.
So, that's another name for it. What is it actually?
There is lymphocytic infiltration.
No, that is a pathology. I'm asking you what is Hashimoto's thyroiditis?
Sir, seen iodine sufficient areas, sir.
Autoimmune thyroiditis.
Yeah, it's an autoimmune. It's also called autoimmune. So it's an autoimmune disorder. So what is hashitoxicosis?
Initially, there is increase in thyroid hormones. Initially, there will be an increase in thyroid hormone levels, leading to thyrotoxicosis feature, followed by hypothyroidism.
Now, what is the difference between suppose I say this is hashitoxicosis.
It will be transient.
Yeah, exactly. It will be transient. How long will it last? What is the difference in mechanism of hyperthyroidism in Graves' disease and both are autoimmune?
Hashitoxicosis, there is destruction of the follicles, and due to that, there will be release of the thyroid hormones.
I couldn't follow. You speak to the mic.
Sir, there will be destruction of the follicles, and as a result of that, hormones are released into circulation that causes.
Yeah, there is inflammation. So there will be release of preformed hormones. So how do you treat hashitoxicosis?
Sir, steroids initially.
Have you seen anyone using steroids in hashitoxicosis? Essentially, you don't need to treat them with anti-thyroid drugs. If they are symptomatic, you treat with beta blockers or calcium channel blockers. Yeah, coming back to.
What are the 4 stages of thyroiditis with regards to the functional status? Because discussions on hashitoxicosis, that's why. And to relate to that, what is the final primary hyperthyroidism with the thyrotoxicosis? What is the difference between hyperthyroidism and thyrotoxicosis?
Sir, hyperthyroidism refers to increased levels of thyroid hormones in the blood.
Increase
Circulating levels of the.
You should be a little more specific. Any increase in circulating thyroid hormones is hyperthyroidism?
Produced by the thyroid.
Production, yes. Production yes, from the thyroid. So what is thyrotoxicosis?
It refers to the biochemical and physiological changes due to.
Any levels of increased. So what are the conditions where you get increased levels of circulating thyroid hormone, but there is no increased production of thyroid hormone?
Sir, struma ovary, then
No,
ectopic.
struma ovary also it produces. What is struma? What is the meaning? Why is struma that? What is struma? Struma is the name of a river in Bulgaria, you know. On banks of this Struma, river Struma, people used to get a lot of thyroid problems. That's why the term Struma came. Anyway, that is not the
What is
question.
stroma ovary? No, I think this problem wouldn't have occurred if the topic was examination of thyroid, or it's a case of thyroid swelling. Now that it is Graves' disease, they've, I think, read everything about hyperthyroidism due to Graves' disease and have read nothing else. That's the issue here. So if it is a thyroid case, I definitely feel all these questions would have been answered.
What is Hamburger toxic? What is thyrotoxicosis? It is an increased level of can you name a few conditions where there is an increased circulating hormones, but there is no increased production of hormones. In thyroid eye, already we discussed one condition. There is no increased production. It's only due to inflammation, increased release of hormone. Okay. What is fictitious thyrotoxicosis? Fictitious.
Endogenous intake.
Yeah, increased intake. There also you may get thyrotoxicosis. It's not due to increased production. What is Hamburger thyrotoxicosis? Hamburger thyrotoxicosis. Hamburger. And what is the mechanism? In some part of the world, they prepare hamburgers with the neck of some sheep and all, which contain thyroid extracts, which can also produce thyrotoxicosis. So that's the difference. Hyperthyroidism and thyrotoxicosis. Hyperthyroidism, I think that was enough. No need to say primary hyperthyroidism with thyrotoxicosis. Primary hyperthyroidism, that's enough. Graves' disease. Yeah. What is the mechanism of Graves' disease? Let's come to the point. What is the mechanism of Graves' disease?
Sir, thyroid TSH receptor stimulating antibodies are there. So as a result of that, there will be.
What are the extrathyroidal manifestations of thyroid Graves' disease, and why it is not seen in secondary thyrotoxicosis?
So there will be eye signs, primary, and there will be neurological features like proximal muscle
You
weakness.
mentioned lid lag and all. What is the mechanism of lid lag in hyperthyroid?
So there will be excessive stimulation of the levator palpebrae muscles and the
Levator palpebrae?
as well as superior.
Are you sure it's levator palpebrae superioris? Why is there lid lag? What is the nerve supply of levator palpebrae superioris?
Oculomotor.
No, it's not it's Muller's muscle.
Muller's
It's not levator palpebrae. Muller's muscle.
What is the eye sign which you can find in secondary hyperthyroidism?
Sir.
Whenever there is a increased sympathomimetic activity, you get this. So that's a clue. In an examination, you said bilobed swelling. How do you know it's bilobed? You said it's a smooth swelling. Is it butterfly shape? In this case,
As a diffuse enlargement.
then why did you say bilobe? So we know thyroid is bilobe, we know, but without getting the findings, how do you say it is? Why do you say it is bilobe? If you are asked to say about anatomy, it's fine. If you say there are two nodules on either side, then you can say. Otherwise, it's a diffuse swelling. What is the size, shape of the swelling in this case?
So the enlargement was diffuse.
Yeah, that's what. So you are not able to feel two lobes here. Why do you say findings which are not there?
Okay, see, eye signs again. Muller's muscles. What type of muscles? Muller's muscle. Okay, anyway, it's a smooth muscle which is supplied by sympathetics. So there will be adrenergic overactivity or stimulation of this, and it produces spasm of the. That's the reason for the lid lag. What is the reason for we said proptosis? What is the reason for that? You said there's some bulging of eye, something like that. You said.
Retroorbital edema, periorbital edema,
No, edema, I don't know.
Now, you said something on the
Infiltration by
skin,
Shin also, yeah,
some
something.
white, shiny, something like. What is that? In your
Plaque,
presentation,
something
in
like
your,
plaques or something like
your
that.
examination, you mentioned general
pretibial
survey or something.
myxedema,
What is mixed edema?
shiny lustrous, shiny lustrous skin,
I am asking you what is mixed edema? What is pretibial mixed edema? Are they the same or different? Mixed edema is profound hypothyroidism. Pretibial mixed edema occurs in
hyperthyroidism.
primary hyperthyroidism.
Why is not seen in secondary hyperthyroid? Three things which is seen only in primary. What are the three padis? What are these three? Which is not usually seen in secondary hyperthyroid.
Dermopathy,
Ophthalmopathy,
dermopathy,
dermopathy,
myopathy,
huh?
myopathy, proximal.
acropathy, acropathy, not acropathy. Why is seen only in primary hyperthyroid? Of the eye signs and the pretibial mixed edema. It's generally seen in primary.
What is deposited?
What is the primary mechanism of pathology of primary hyperthyroid?
There will be
Which antibodies are there?
thyroid, the TSH receptor.
TSH receptor antibody. Okay. So they cross-react. There may be some TSH receptors in retrobulbar tissue and the skin, and it will be okay. So deposit glycosaminoglycan. That's the mechanism.
Did you inspect or did you palpate for pretibial mixed edema? What you are describing is probably pretibial mixed edema. Did you actually see it on this patient, that white shiny thing
It was white.
you saw? Then why did you not palpate? In a case like this, if you are saying there is something shiny there, which part of the tibia you find this?
anterior
It's just 1 centimeter below the tibial tuberosity. What is deposited there in pretibial mixed edema in front of the shin?
collagen,
It's the same
Like-
thing which is deposited in the retrobulbar region. It's the same mechanism, the exophthalmos and pretibial mixed edema.
glycosaminoglycan.
Yeah, so it's some mixomatous substance getting deposited here as well as there. What is the advantage of getting this finding? Suppose you find routinely you palpate, you will find in most cases of Graves' disease. The problem is we don't palpate. If you palpate and you're able to get on both shins, just below tibial tuberosity and elevation, a soft tissue elevation, it is hallmark of this disease. So what is the advantage? Anyway, you know it's hyperthyroidism. I'm going to treat with antithyroid drug.
Assessment of treatment,
So that is diagnostic
Right.
of primary hyperthyroidism. Otherwise, how do you diagnose?
biochemical test.
In this, how will you, okay, it's a very evident case of probably hyperthyroid. All signs are. How will you investigate and manage this?
So we will proceed with the biochemical test. We will send in for a TFT and also for antibody. Then we can do an ultrasound,
Huh?
USG neck
USG neck.
imaging.
What is the purpose of doing USG?
So, three things can be assessed. First of all, about the lobe,
We can't hear.
about the consistency size of the lobe can be assessed. Then lymph node status can be assessed. Then very
Consistency cannot be assessed. Yes.
size surface. Then
Lymph nodes, why lymph nodes? In hyperthyroidism, you get lymph nodes. You suspect malignancy. What is the percentage of malignancy in thyrotoxic or hyperthyroid? Chance of malignancy in a toxic thyroid. nodule. This is not nodule, it's a diffuse thyroid. What is the percentage of malignancy?
It's relatively low, but it's not absent. It can occur. Now, point is, what is autonomous toxic nodule? Otherwise called toxic nodule.
Toxic adenoma.
Sir, one nodule will be the dominant nodule that produces the hormones in this situation. There are chances of it being malignant. It is an indication for doing the
Toxic
isotope scan.
adenoma is probably the only condition where malignancy never coexists. I've seen one case, but literature-wise, it doesn't coexist. What is diagnostic test where you can distinguish between these two conditions?
Isotope scan. Isotope
Between multinodular, secondary toxicity, primary toxicity, and this toxic nodular and Graves' disease.
Sir, we can do an scintigraphy, isotope scan.
Isotope scan. Now,
Isotope
the ultrasound can pick up nodules. The ultrasound
let
doesn't
us
show
ask.
nodules, it's diffuse.
What is the isotope finding in all these three? Diffuse, sir asked no. Diffuse thyroid swelling, toxic adenoma, and multinodular secondary type of
so there will be diffuse uptake in the case of
diffuse uptake. What will happen in toxic adenoma?
increased uptake.
Increased
What will
uptake,
happen to the remaining
remaining
thyroid?
thyroid.
Remaining thyroid, what will happen? What will be the appearance?
Less uptake. I mean,
No uptake.
no, sir.
That will be suppressed. So the raised thyroid.
Well, one last question. How do you manage
Treatment of
a toxic nodule?
Sir, we can start the patient on antithyroid medications and beta blockers.
And, okay,
With-
controlled. Patient is now controlled.
A patient now?
Now under control.
Sir,
toxicity control.
You have treated and patients now come under control.
sir, radioiodine ablation. We can, this patient can, we can,
Okay, this patient is a Graves' disease.
sir,
How will you manage this particular patient? What is the treatment?
Antithyroid drugs.
Antithyroid drugs is not a treatment, it's only for preparation. Can't go for long term.
You mean medical treatment? You don't want to do surgery, medical treatment. Acceptable.
But it's not a permanent treatment. You need to do something. So only for a preparation. What is the permanent, complete curative treatment for Graves' disease?
total thyroid.
Surgical? What is treatment of choice? Given in the books.
There are three options in treatment. One is, as you said, medical treatment. Because if you treat for 18 months and there is a remission, spontaneous remission occurring in that, only 50% will develop recurrence, which means 50% get a complete cure with medical treatment, no surgery, no radiation. Second is radioiodine.
Radioiodine ablation.
Whereas in some centers, they prefer radioiodine.
Yeah, in books, if you see the treatment of choice for Graves' disease,
Radioiodine.
Okay. Surgery is indicated when, what are the definite
What are the indications for surgery where
in Graves'
both
disease?
these doesn't work?
Sir, when the patient, when antithyroid treatment itself, if it does, when the patient is not compliant to radioiodine therapy,
Compliant to radioiodine.
sir, let me not, in contraindication, radioiodine therapy less than 5 years, then if the patient is pregnant,
Okay.
Pregnancy maybe, yes.
Yeah, okay. Contraindication. Next.
compression symptoms, large toxic,
Yeah,
large
large
nodule-
goiter. Large goiter.
Large
the-
goiter.
goiter,
the thyroid function will come to
And
normal.
also the all systems of doubtful malignancy. Any contraindication. Okay. What are the other contraindications for radioiodine? Or contraindications for radioiodine and Graves' disease when you don't want to give
Pregnancy.
pregnancy,
Lactation.
lactation, less than 5.
No, when there are ophthalmopathy
After,
as well as heart disease. So this can aggravate. Radioiodine can aggravate these symptoms. So when these are caused, surgical method.
Last question. How will you prepare a patient, thyrotoxic patient for surgery, preoperative preparation?
Lugolzidine for 10 days is given to make the patient euthyroid. After that,
Then when will you give the last dose of carbimazole?
day, till the day before surgery.
Okay, or on the day of surgery. Then propranolol after surgery, is there a role for giving?
Sir, we will continue propranolol after surgery.
Yes.
This is necessary to give propranolol in every case of hyperthyroidism. When you're treating medically, you said you will also give propranolol along with the antithyroid drugs. Is it always necessary to give propranolol?
Sir, for controlling the cardiac symptoms.
No, I am not asking why you will. You give always.
No, sir. Initially, we give only and
What are the indications where propranolol should be given alongside antithyroid medications?
cardiac manifestation, hypertension.
Yeah. So patient is elderly, patient has got cardiac disease, patient has tachycardia, which produces symptoms. Yes. Thank you very much.
Thank you.
Thank you very much.
Presentation
Sirs.
was good, but the preparation was not. I suppose you already know that. Thank you.
For our next topic presentation, may I also invite Chairperson Dr. Maharajan, please, on the dais. I request the examiners to please continue on the dais. Topic presentation will be made by Dr. Tansir, Department of Nuclear Medicine, MBR's Cancer Center, Calicut. Invite Dr. Tansir, please.
Started.
Please, sir, go ahead.
Good morning. At the outset, I would like to thank the organizer for giving this opportunity. So, topic of my presentation is a role of radioisotope in thyroid disease. So, I will be discussing in the following order: role in benign disease and role in malignancy. So, as thyrotoxicosis is a clinical state that results from inappropriately high thyroid hormone action in tissue, generally due to inappropriately high tissue thyroid hormone level, and hyperthyroidism is a form of thyrotoxicosis due to inappropriate high synthesis and secretion of thyroid hormone by the thyroid. So causes include excessive TSH receptor stimulation, which is seen in Graves' disease, TSH secreting pituitary adenoma, TT receptor mutation, and chronic gonadotropin secretory tumor, and autonomous thyroid hormone secretion seen in toxic MNG and toxic adenoma, and destruction of thyroid follicle seen in thyroiditis, and extrathyroidal source of thyroid hormone seen in factitious thyroiditis, stroma ovary, and metastatic differentiated thyroid cancer. So apart from the clinical history and examination, the investigations are also important. The evaluation of thyrotoxicosis include blood investigation like thyroid function test and autoantibodies and thyroglobulin, radiological investigation, ultrasound, and nuclear imaging investigation, thyroid scan, and radioiodine uptake scan. So coming to the thyroid scintigraphy, this is thyroid scintigraphy can be done using I-123, which is not available in India, then I-131 and technetium pertechnetate. Technetium 99 pertechnetate is most commonly used for thyroid scintigraphy. This is the normal thyroid scintigraphy using technetium pertechnetate scan. Usually for adult, you inject around 4 to 5 millicurie of technetium pertechnetate and do the imaging after 20 minutes. This is the normal scan which is showing homogeneous uptake, tracer uptake in the both lobes of thyroid gland. This is a right lobe, this is a left lobe, and there is a physiological uptake in the salivary gland, submandibular and parotid salivary gland. So it should be performed when the clinical presentation of thyrotoxicosis is not diagnostic of Graves' disease. In Graves' disease, there is a homogeneous increased uptake throughout the thyroid gland. In toxic MNG, there is a heterogeneous pattern of uptake with the hyperfunctioning nodules that demonstrate increased radionuclide uptake on scan, and solitary toxic nodules show uptake in the hyperfunctioning nodule with a decreased or suppressed uptake in the remaining thyroid gland, and thyroiditis show absent or very low uptake. So these are two images which is on in the screen. This is the first images. This is the right showing diffusely enlarged both lobes of thyroid gland, showing increased tracer uptake. So there is a background or almost suppressed, and normal uptake is showing around 30.8% at 20 minutes. And this is another image, which is a image. This is a case of thyrotoxicosis patient, and there is no uptake in the region of thyroid bed. So that is the case of thyroiditis. But before labeling thyroiditis, we had to rule out the other causes of thyroid contamination, like recent IV contrast study and all. So in Graves' disease, usually history will be more than 3 months, and thyroiditis, that means subacute thyroiditis, especially recent history of less than 3 months, with associated fever and sore throat. And the physical examination, Graves diffuse and enlarged, and in thyroiditis there is tenderness in the neck or thyroid bed, and ESR and thyroglobulin levels are normal in Graves' disease, and in subacute thyroiditis is rise. And T3 T4 ratio is more than 20 in Graves and less than 20 in thyroiditis, and uptake is high in Graves and low or zero in thyroiditis. This is the 3 images of patient. This image, which is you are seeing a increased uptake in the region of left lobe of thyroid gland. You are not seeing in the nothing in the right lobe. This is a solitary toxic nodule which suppresses the right rest of the thyroid gland. This is a multiple foci of increased tracer uptake in the region of thyroid bed. This is a case of toxic MNG. And this is another case which is showing normal uptake in the left lobe. There is a photopenic large decrease uptake, that is photopenic area or cold nodule in the region of right lobe of thyroid gland. So most of the nodule are cold nodule, and among this nodule 15 to 20% of cold nodules are malignant. So management of hyperthyroidism due to Graves' disease, management consists already discussed. Management consists of medical and surgical and radioiodine ablation. So long-term quality of life following Graves' disease was found to be same in patient and randomly allocated to any one of these treatment options. And many centers prefer antithyroid drugs. Many countries prefer radioiodine therapy, and there is no single approach is optimal, and the patient may require multiple treatment to achieve the remissions. So factors favoring a particular modality. First of all, antithyroid drug. So it is mainly recommended in patients with a high likelihood of remission, in women with mild disease, small goiter with a negative or low tyrotropin receptor antibody, pregnant woman. Then surgery is mainly indicated in very large goiter, symptomatic causing symptomatic compression, or suspected or documented associated malignancy. Then coexist in hyperparathyroidism requires surgery, and moderate to severe active Graves of ophthalmopathy. So radioiodine ablation is usually recommended in female planning pregnancy if more than 6 months, because if you are doing the radioiodine therapy, it should not be pregnant up to 6 months. So if there is a comorbidities increase in surgical risk, and previously operated or externally irradiated neck, and lack of access to high volume thyroid surgeon, and if there is any contraindication to antithyroid drugs, and failure to achieve euthyroidism with antithyroid drugs, we can consider radioiodine therapy. And radioiodine therapy is contraindicated in pregnancy and lactation, and if it is associated with coexisting thyroid cancer or suspicious thyroid cancer, and if it is unable to comply with the radiation safety precautions, and if patient is planning pregnancy within the 4 to 6 months. So preparation of patients with Graves' disease for radioiodine therapy. So because radioiodine therapy can cause transient exacerbation of hyperthyroidism, beta-adrenergic blockers should be considered even in asymptomatic patients who are at ring risk, like elderly patients and patients with comorbidities. So in addition to beta blockers, pre-treatment with methimazole prior to radioiodine therapy should be considered in patients who are at increased risk for worsening of hyperthyroidism. So iodinated radiocontrast should be avoided, and nutrition supplement that may contain excess iodine and seaweed should be avoided for at least 7 days. And methimazole, carbimazole, and propyl thiouracil reduce the success rate if given in the week before or after radioiodine therapy. If the patient has severe hyperthyroidism, can give methimazole after 1 week of radioiodine therapy, and there is no special diet required for before radioiodine therapy. So iodine is the radioisotope used for radiation therapy. It's a combined gamma and beta emitting radioisotope with the physical half-life of 8 days. A gamma emission of energy of 364 keV and beta energy of beta max of 607 keV. So the sufficient activity of radioiodine should be administered in a single application, that is about 10 to 15 millicurie. And a pregnancy test should be done in the case of a woman with a childbearing age. And goal of radiation therapy is in Graves' disease to control hyperthyroidism by rendering the patient hypothyroid. And the conception should be delayed in women until stable euthyroidism is established, at least 4 to 6 months or longer. So conception should be delayed 3 to 4 months in men to allow for turnover of sperm production. And there is no evidence of reduced fertility, and offspring of treated patients show no congenital abnormalities after the radiation therapy. And after the therapy, the follow-up within the first 1 or 2 months with free T4, total T3 and TSH is recommended, and biochemical monitoring should be continued at every 4 to 6 week interval for 6 months or until the patient become hypothyroid and is stable on thyroid hormone replacement. And that beta blockers that were instituted prior to the radiation treatment should be tapered when free T4 and total T3 were returned to the reference range. And when the hyperthyroidism due to Graves' disease persists after 6 months following radiation therapy, retreatment with radiation is suggested. In patient with minimal response 3 months after therapy, additional radiation may be considered. So coming to the role in malignancy, so radiation has a main role in thyroid malignancy. So in especially means in differentiated thyroid cancer. So thyroid malignancy after the surgery is divided into 3 groups according to American Thyroid Association guideline. So ATA low risk include intrathyroidal non-aggressive histology papillary thyroid cancer up to 5 lymph node micrometastasis, that is less than 0.2 centimeter. Then follicular thyroid cancer with capsular invasion and up to less than 4 foci of vascular invasion. So radiation is not usually recommended in the low risk group, but depending on the post-op evaluation, that means after 3 to 4 weeks of surgery, assessment with stimulated thyroglobulin and radioiodine uptake scan. If it is showing any abnormality, we can consider radiation therapy. In intermediate risk, papillary carcinoma thyroid with extrathyroidal, either microscopic or radioiodine extension, and aggressive histology, that means hobnail, columnar or tonsil variant, and then vascular inversion or more than 5 lymph node, all lymph node with less than 3 more than 0.2 to less than 3 centimeter. Then high risk microscopic residual or distant metastasis, any lymph node with more than or equal to 3 centimeter include high risk, and follicular thyroid cancer with more than 4 foci of vascular invasion also included in the high risk. So intermediate and high risk group radiation should be given. So the chance of structural disease recurrence is high in the case of high risk group, and this initial recurrence risk estimate should be continuously modified during the follow-up. It's a real-time dynamic risk stratification scheme. So why the differential thyroid cancer treatment is different? Because iodine is 131 is an important weapon, and DTC, differential thyroid cancer, meds retain iodine concentration ability, but it is less than that of thyroid gland. And thyroidectomy should be done because it is for the removal of thyroid tumor and to facilitate the detection and treatment of metastasis with radioiodine. So this is thyroid cancer. This is spectrum from the non-invasive papillary thyroid follicular means non-invasive follicular. Non-invasive NIFTP, then aggressive PTC, then aggressive PTC, non-aggressive PTC, then aggressive PTC, then widely invasive FTC, solid variant of PTC, poorly differentiated PTC, then anaplastic. This is a spectrum. Then usually the FDG has no role in thyroid malignancy, but it is recommended in the case of differential thyroid cancer with elevated serum thyroglobulin and negative radiation scan, that is TENIS. and it is recommended in the part of initial staging in poorly differentiated thyroid cancer and invasive Hürthle cell carcinoma, and the evaluation of post-treatment response following systemic or local therapy of metastatic or locally invasive thyroid cancer. I will show you a few of the images. This is a case of follicular 55-year-old male patient with follicular carcinoma thyroid. This is a post-op diagnostic I-131 scan showing remnant uptake in the right lobe, and there is the 4K of trace uptake in the region of mid-dorsal vertebra. This is an anterior image, this is a posterior image. So this posterior image shows multiple skeletal sites in the pelvic region and the mid-dorsal vertebrae. And this initial stimulated thyroglobulin was 221. This patient received 200 millicurie of radioiodine therapy, and this is a first follow-up after 6 months. There is this showing complete resolution of thyroid remnant and skeletal lesion, and TG become normal, and similar TG become normal. So this is another patient. This is a patient of follicular thyroid cancer post-op. This showing there is a thyroid remnant, and there is a diffuse uptake in bilateral lung, and there is a skeletal lesion in corresponding to L4 vertebra. The initial thyroglobulin was 2500. This patient, this is the first follow-up scan after 6 months. TG became 800. There is a still persisting lesion. This is a scan after the third dose. There is a complete resolution of lung nodules, and there is a persistence of L4 vertebral lesion. So usually lung lesion, if it is a micrometastasis, showing complete response with radioiodine therapy. So lack of time, not going to other images. So this can discuss. This is another case. Not all differential thyroid cancer shows radioiodine avidity. This is a case of a 62-year-old male patient of papillary carcinoma thyroid, initially treated in 2013 with surgery and radioiodine therapy. This patient stimulated thyroglobulin was 12, but patient presented with a hoarseness of voice, but diagnosis scan showing only few uptake in the region of neck. And this patient underwent a FDG PET-CT, which is showing multiple foci of intensely FDG lesions in the thyroid bed and left supraclavicular and mediastinal lymph node and bilateral lung nodules. So the few cases does not shows this radioiodine uptake, and does not shows any improvement after radioiodine therapy. So conclusion, radioisotopes are very much useful in the evaluation and treatment of thyrotoxicosis and differentiated thyroid cancer. Radiation safety precautions are important after therapy, and side effects are generally mild and infrequent and self-limiting. Thank you.
Nice presentation. One question.
Yes, sir.
See, you mentioned about the de-differentiated malignancies, that thyroglobulin will be elevated, but radioiodine uptake will be low.
Yes, sir.
So you go for PET scan.
Yes.
How will you treat that state? Can you give high dose of radioiodine, still they will respond, or you go for some other modality?
Yeah, actually, I had one image that I didn't show. We can consider one dose cycle of empirical radioiodine therapy using high dose of radioiodine therapy.
You give radioiodine. Right?
Yeah, what we do is we usually follow with 6 monthly. If sometimes TG may not be high, if the TG is high within 6 months, or it is elevated, its doubling time is very high in the 6 months, we consider one dose of radioiodine therapy. And we structurally we also see, we may image with PET-CT or CT scan. If it is progressing, we will refer to medical oncology for TKI and all. Otherwise, we keep on observing. Most of the time, it is slowly progresses.
But they respond with high dose of radioiodine. That's what it is. Sometimes they respond.
Sometimes 50% chance is there, up to 50%.
Sir, one more just to add. Very nice presentation, Dr. Tansel.
Thank you, sir.
Congratulations. We have touched all the topics. One small information regarding that de-differentiated thyroid carcinoma, where FDG glucose is taking and radioiodine is not going. The purpose of doing a PET scan is to identify the abnormal metastatic cells. Sometimes it may be easily accessible by surgery. That is one of the main reasons. If thyroglobulin levels are very high, you do a PET CT scan. Suppose there is a lymph node in the mediastinum, or there is any other lymph nodes in the abdomen where you can surgically access. You can surgically remove that metastatic lesion and you can aim for a complete cure of the patient. We have seen
Yes,
few
yes.
cases
Yes,
where
sir.
FDG PET has diagnosed lymph node metastasis in the chest, and with the help of a chest surgeon and a surgeon, you remove the lymph nodes and give the patient a cure.
We also had one patient, sternal metastasis, and then did sternectomy followed by radiation. That patient,
So who are not candidates for surgery, they go for a medical man. That is the main part.
What will you give at that time? Supposing it, the surgeon says it's unresectable.
unresectable with multiple metastasis. So, more this thing, if we keep on follow up the patient, if the patient because if it is progressing, so then we'll give TKIs, tyrosine kinase inhibitors.
Suppose the
Landmark.
disease is in the neck, it's infiltrating the carotid.
Ah.
Therefore, surgeon say, is there a role for external beam radiotherapy?
Yeah, if the disease in the neck and if it is infiltrating the surrounding structure, there is a role for radiation, external beam radiation.
Questions from the floor?
Good morning, Dr. Dhansir. Excellent
Good
talk.
morning. Good morning, sir.
Just wanted to know about suppose the bulk of the disease, as sir mentioned now, is unable to be removed, and the external beam radiation is being given. What is the role of radioiodine in these scenarios? Will the dose be adjusted according to the bulk of the disease?
You are saying it's a case of thyroid malignancy.
Yes, malignancy.
So R2 resection, you are saying.
Yes, R2 resection. Yes.
So and it is a high grade.
Yes.
Actually, most of the time, if it is a very large thyroid tumor, if it is unable to do the resection, so radiation may not be so much useful. So, how much, if maximum, and the treatment of radiation is useful depending on the completeness of the surgery. So, maximum if you can remove, the treatment will be that much effective. So if it is large bulk tumor, it may not be useful, but we tried one or two, two patients because it was a large tumor engaging the carotid and all, but it was not much useful. But if you can remove the maximum, that treatment will be that much useful with the radiation.
It's almost like a scenario which Professor Sunil sir has mentioned just now. So.
Yes, and but it's a very large tumor, is very difficult.
Thank you.
Serial follow-up with TG and localization by any method, failing which you go for FDG PET. The reason for that is to, one, localize, and if it is surgically removable or external beam RT, isolated things, even vertebral body can be removed. Lung metastasis, all three can be removed. Coupled with external beam RT is an option, particularly in the spine, long bones, where there is a pathological fractures.
What is the maximum cumulative dose of radiation that you can administer?
Pardon?
What is the maximum cumulative dose of radioiodine which you can administer in a metastatic setting?
So usually give up to 1000 millicurie. So 5 sessions in it.
Lifetime dose, isn't it? Lifetime 1000 or in one setting you can give 1000.
No, one setting maximum 200 millicurie.
It's the lifetime maximum dose
1000. But when we attended a conference, one big professor from USA, sir said he gave up to 2200 millicurie, and patient was completely asymptomatic.
1000 is a multiple times. At a time he is telling maximum 200 millicurie. So in a multiple bone mets cases, you can give 5 times. So 5 into 200 comes to 1000. Suppose sir was telling about a final case where there is a tumor tissues, the external beam. In that case, we can extend a little bit more.
Yes, sir.
Probably 200 or 300 more out of that, because there are no options. Even external beam radioiodine therapy also will not be that much useful when radioiodine is not concentrated.
Okay, thank you.
Thank you, sir.
We'll wind up the session.
Thank you very much to our esteemed examiners and chairperson of the session. A couple of announcements before we move on to the next session. All the posters exhibited in the hall behind the seats. Postgraduates may please take the photographs from this site. Site of poster presentation of the selected candidates for the competition will be announced. Competitions will take place in the conference hall on the ground floor, and details will be announced shortly. The algorithms have been put up outside the hall, and we request the PGs to kindly visit them during your breaks. Also, an exhibition of paintings by Dr. Sajjan is on display outside the auditorium. Kindly give it a visit, please. Thank you. We have the master lectures next. May I please invite the chairpersons for the session, Dr. Santosh John Abraham, Dr. Shamshad Begum, Dr. Shabir Ali, please, and Dr. Rajesh. The first talk is by Dr. T.V. Haridas. May I hand over the proceedings now to our esteemed chairpersons. We request the speaker to kindly maintain the stipulated time, please. Thank you.
Good morning, all. First of all, I take this opportunity to thank the organizers, especially Dr. Gamaliel sir, Jose Gamaliel sir, as well as Dr. Siddiq, for giving me a chance to participate in this program. The first topic that we are going to start is preoperative optimization of abdominal surgeries. And now we can hear what is his views regarding the optimization of the surgical abdominal surgeries. Over to you, Dr. Haridas.
Thank you, ma'am. Thank you, organizers, for giving me this opportunity. Let us jump from thyroid to abdomen for the time being. See, it's a very vast topic, so I thought I will stick to this program, to this particular index case for colorectal cancer patient, 70-year-old man coming for surgery. So we will be discussing some aspects. We can't go to every aspect of the management, preoperative optimization of this particular patient. So I'll be going through these topics: the bowel preparation of a patient, prehabilitation, what do you mean by prehabilitation of a malignancy abdomen, nutritional assessment and prehabilitation, and what is the role of preoperative antibiotic, and some ISA, the Indian Society of Anesthesiologists guidelines with madam around. Bowel preparation, the rationale behind that is that remove the high bacterial load from the colon and leaving the hard stool from the colon will reduce the luminal pressure, and handling of the bowel becomes easier, and palpation of smaller lesions also becomes easier. Various methods of bowel preparations are there: the mechanical one, the oral antibiotics, combined methods, enema, bowel wash, diet restriction, so many. So I will be going through some details about mechanical bowel preparation. They are taken by mouth and clear the colonic contents. The osmotic ones are available, which is one absorbed one and non-absorbed one, stimulant laxatives, and combination of all these. Sometimes some people use this. Osmotic agents pull the water into the colonic lumen, thereby helping the evacuation. The absorbed ones are the magnesium citrate, sodium phosphate, but the problem is that they may produce a little bit of renal impairment and hypertension may be aggravated. Non-absorbed ones, the PEG, the commonly used one, which again there are with electrolytes and without electrolytes. This is the with electrolyte composition of electrolytes with electrolytes one. The electrolyte solutions usually a salty in taste, and people may produce less electrolyte imbalance. Commercially, the 4 liter and 2 liter formations are available, but this can be used in renal and congestive cardiac failure. Various dosing schedules are available. Some use one single dose previous of 2 days before, or split dosing, previous day half and in the morning half. Whatever you do, the colonic evacuation should be complete, otherwise half prepared colon with liquid fecal matter, which is more dangerous than the non-prepared colon. Stimulant laxatives can be used, bisacodyl castor oil, they produce less cleansing, but you have to start 1 to 2 days prior to that, and a combination of all these can also be tried. whatever you do, you should try to achieve the three, and either 2 or 3 type of Boston preparation, bowel preparation scale. The 1 and 0 are poorly prepared bowel, especially for this is colonoscopy grading, but this can be applied into the bowel surgery also. And the mechanical preparation is not without problems. Lot of problems for this patient, like fatigue, dehydration, electrolyte imbalance, perforation, pain, abdomen, all this. So what is the data saying about my mechanical bowel preparation with regards to this SSI and leakage? They say there's not much role. This is a very busy slide. I agree. They're not saying, they're saying this is not very much useful in preventing SSI as well as bowel leakage. Oral antibiotics for tried colony bacteria is about 10 raised 12 CFU per gram. And the non-absorbed antibiotic like neomycin, kanamycin, metronidazole, erythromycin, now they use a lot of newer antibiotics are there. Usually they give previous day 2 p.m., 3 p.m., 10 p.m. dose. Some people do this. And what does they say? Combination of MBP and oral antibiotic. They're seeing some benefit in the controlling SSI and leakage, especially SSI is less after combination of MBP and OA. There are various meta-analysis. And so that's what I was saying, showed some reduction in SSI and leakage in many meta-analysis. What about rectal surgery? Almost similar value, similar things you can see in the MBP. When it's combined with MBP and oral antibiotics, again, they're showing some benefit in the rectal surgery also. So what about no preparation? Some people are they don't like to prepare, so they do no preparation. Easier because it's easier return to bowel activity in lesser hospital stay. And many studies have shown there's no difference in anastomotic leak or SSI if you prepare or no. And also it's part of ERAS protocol. So this is the various RCTs, combination of RCTs regarding MBP with no MBP regarding SSI and anastomotic leak. Interestingly, some of the prepared colons have got more complications in this RCT, various RCTs. Prepared ones have got more complications. So where do we stand? Actually, there's no consensus about bowel preparation. MBP is not preferred by many. MBP alone is definitely not going to reduce SSI. But there may be some indication, like if you're planning for an on-table colonoscopy, anorectal procedures, because we have to do stapler using will be more easier, and left colonic lesion. Right-sided colonic lesions, many people don't prefer it, and the role is not very clear. Next topic, I would go to malnutrition. Because people will be malnourished to come for bowel surgery and all. So they'll be having the clinical evidence by hair, easy pluckability, face show meniscolabral seborrhea and all, muscle bulk, thinner, lumbrical, loss of muscle bulk, skin will show increased fold, hyperkeratosis, and limbs show edema. So these are some of the signs of malnourished people who are coming for abdominal surgery. So this is one study, they show the adductor pollicis muscle, which shows the parameter for malnourishment below 5th percentile. So what are the postoperative effects of malnourishment? It could produce anastomotic degradation, sepsis, immunosuppression, and more hospital stay. This is one recent Korean journal which is substantiating these points. So there is an ESPEN guideline for the malnourishment, so which says weight loss more than 10 to 15% in the last 6 months, BMI less than 18.5, SGAC and NRS, whatever, I will come to this in point shortly, and serum albumin level less than 30. So these are some of the parameters which suggest severe nutritional risk. So we have to correct it. So these are the various nutritional assessment things. I'm not going to elaborate everything. I will just go through some slides of that. Subjective global assessment, patient generated one, prognostic nutritional index, everything. So I will go to this one by one in the next few slides. This is the subjective global assessment, which is a gold standard. What they suggest is consider the medical history of this patient with regards to weight change, dietary history, GI symptoms, etc. And physical examination finds subcutaneous fat loss, muscle wasting, etc. And there's a grading. A is okay, SGSC is very severe malnourishment. So when the SGSC, there's more complication, increased hospital stay, subjective, but it's a subjective analysis. There's no objective tests no invasive tests are there. It's a bedside questionnaire type of analysis. Another one is prognostic nutritional index, which measures serum albumin and total lymphocyte counts. And there's a complex formula whereby you calculate if it's PNA high for 44.5 and high, it's easier, better one. If it's low, less than 44.5, people have more complications. Another one is nutritional risk index, NRI. They consider serum albumin and weight loss. And again, there's a complex formula. More than 100 is the ideal score. Less than 83.5, patient have more severe nutritional impairment. So these are some of the assessment methods. Then again, there are more. Malnutrition universal screening tool must. That accounts for BMI, weight loss in previous 3 to 6 months, and there are scores available. Another one is nutrition risk screening, Rayleigh's nutritional risk score. So many ones are there, but easier ones. This is the best one to use for all of us. The other ones are little cumbersome. Simply measure the albumin. If it's less than 3.5, it's associated with more complications and the best single parameter. All abdominal surgery cases, especially malignancy, if you can optimize patients with albumin to around 3 to 3.5 before surgery is the best. So, but problem is there may be some non-nutritional factors which can alter the value, and albumin has a long half-life, which may not represent the recent nutritional deficit of a patient. Next group of things will be anthropometry. We know the weight, height, BMI, everything. Mid-upper arm circumference, head circumference, skin fat and fold thickness like subscapular, iliac and tricep skin fold thickness. These are all subjective, these are, objective methods, but not very accurate. Okay, fine. So this is how you measure the skin fold thickness. There's a special caliper where which you can measure the skin fold thickness. And this is actually for the frailty test is the Freud's phenotypic definition. This is actually not for specific for abdominal surgery or any surgery. Any old people coming for surgery, there is a frailty, Freud's frailty phenotypic definition. 3 of the 5 traits, if they're positive, we can consider this patient as a frail patient, like slow walking speed, low gripping strength, declining activity level, unintentional weight loss in the recent times, and exhaustion. These patients, and especially when they're old, we have to consider them for prehabilitation. So you should undergo prehabilitation with multidisciplinary techniques, programs to reduce stress, settings, realistic goals in these patients, and physiological age is considered, not chronological age. We quite often use the term sarcopenia, which is just means loss of flesh. It is definitely, by definition, is the age-associated loss of skeletal mass and function, which is represented by gait speeds and grip strength loss. But we commonly use cachexia. It's actually a type of sarcopenia, which is secondary to some cause, like in majority of our cases, malignancy or some surgical disease. So what happens if there's sarcopenia? There will be more complications, more hospital stay, and more mortality. So this sarcopenia can be assessed by various means like bioelectric impedance methods, dual electric energy X-ray absorptiometry, and this is not a very good, less accurate method, but it can assess the lean mass, which is non-fat and non-bone lean mass. And there is a formula, there is a appendicular lean mass index can be calculated by this ALM divided by height square. And women, if it's less than 5.5, men less than 7, we consider it as a malnourished patient. But the best way to assess the muscle mass or sarcopenia is CT scan. Anyway, we will be doing a CT abdomen. So we can assess the psoas and abdominal muscle mass at L3, 4 or T4 level. Why this level? Because this level is least affected by movement. So we can, by doing it CT scan abdomen, we can look at the psoas muscle and the abdominal muscle at this level, we can assess, and there's a formula, skeletal mass index can be calculated, which is complicated, I didn't write it here. So we can assess, we can assume that patient is nutritionally deficient. MRI can also be used. So this is some of the pictures. This is the green index. This is fatty tissue, and the red shows the parenchymal organ, and this one represents the muscle. So they can easily assess the muscle mass and calculate the bulk. If there is nutritional or anthropometric deficiency, there should be people go for something called trimodal prehabilitation program. Okay, it should be 1 month. Trimodal nutritional, one is nutritional counseling and supplementation of whey protein and protein supplementation. Second is anxiety reduction by incorporating psychotherapies and all. Third is exercise. And prehabilitated patients show better recovery. So, is there any role for peripheral parenteral nutrition? Not really, but when parenteral nutrition is not sufficient, you can go for this. Or at least for 4 days prior to surgery, in addition to enteral nutrition. If the patient is on enteral nutrition for protocol, 4 days prior, if you can give parenteral nutrition with vitamins and trace elements, it will give better results. Also, don't forget arginine and N3 fatty acid immunonutrition improves immunological function. So this is what I was saying, nothing new in that. So this now comes to anesthetist area. This is anesthetist area. They do some tests like cardiopulmonary exercise testing, the CPET. It's a dynamic testing because fitter patients produce lesser complications. Basically, they assess the cardiac, pulmonary, metabolic, and hematology parameters, and this is the gold standard assessment for them. So what they assess is usually these parameters: external work ability, exercise capacity, metabolic gas exchange, ventilatory, pulmonary, cardiovascular, and any symptomatology they assess. And depending on that, if they can find out if a patient is having any need any prehabilitation. So the dotted line patients are rehabilitated patient, and this is the ideal level that these dotted line. These are non-prehabilitated patients. So they will find the prehabilitated patients, they recover but much better than the non-prehabilitated patients. So what they do, they should be asked to do, patients should be encouraged to do exercise at least 150 to 300 minutes a week, which may include aerobic or muscle strengthening exercise, or as much as they can, because we can't ask the malignant sick patients to do whatever exercise we suggest. And ideally it's 4 to 6 weeks time. So there is a box scale. This is the easy exercise 0. 10 is very, very hard exercise. In our patients, we should achieve somewhere 5, 6, and 7. If they can do the somewhat hard exercise for a period of time, it will be better rehabilitation. So I'm not going to discuss this preoperative fasting. We already know it. Carbohydrate drink is there in the domain for quite some time. The osmolality low, 300 milliosmol per kilogram. High carbohydrate, 12 gram per 100 ml. 2 hours prior to surgery. This is all part of the RAS protocol. 2 hours prior to surgery in the morning, patients can drink this solution. Other smoking cessation for 4 weeks and alcohol, antibiotic prophylaxis can be considered. These are all RAS protocol, 1 hour prior to incision. And the latest thing say, you should not give it for 24 hours. The previous thing was saying, last 2 slides. Saying if about 24 hours, but before stopping this, closing the skin, you should stop it. Venous thromboembolism and nothing. So now this is an area, I think especially for Madam, Indian Society of Anesthesiologists, there's a protocol. What they say is must do surgery, must do investigations for all major surgery. They didn't specify abdominal. These are the must do investigations. In this they have, this is a not must, electrolytes, PTINR, US assessment of the airway, but definitely not for abdominal alone. So electrolytes and PTINR may be must for abdominal surgery, I feel, but they didn't specify. And this is very important. The validity time for previous investigations is acceptable time interval from previous testing for any purpose to current preoperative evaluation. That means whether we should repeat an investigation or not. Okay, so these things, CBC, RFT, LFT coagulation profile, they're done 2 months period prior to this, or ECG or X-ray just done 12 months prior. We need not repeat it. That's what anesthesiologists say. But provided the condition of the patients remains stable in this period. Okay, so with Madam, God bless us, they may not ask us to repeat many investigations, especially in government setup. So to summarize, the optimum perioperative management requires multidisciplinary approach. Accurate preoperative risk assessment is essential, which help in the choice of procedure and appropriate level of management. And prehabilitation leads to better rehabilitation. Thank you very much for the patience.
Thank you, Haridas sir. As usual, you were, when we joined for 3rd year MBBS first surgery class, you were our lecturer, and you are an inspiring teacher at that time itself. And when I heard this topic, it is a too vast topic. You have many things to discuss, like even in emergency surgery or elective surgery, or when you come to upper GI cancers, hepatobiliary cancer, it's all different. So I was thinking how you are going to present it when I was told to chair this session. But you nicely narrated the most relevant things, like you choose that colorectal bowel preparation issues, and then nutritional and frailty scores. We do have done some work on this as a PG dissertation. Last year we completed one study on this frailty. Frailty, and we tried all those things, including the psoas muscle index, and then those frailty test assessments like hand grip dynamometer, hand grip strength, and other things. And we found out that time to get up and walk, that time, 6-minute walk test, and those two came as only 2 indicators which came as significant in patients undergoing major abdominal surgery. Other psoas muscle index and all, the problem was we tried to standardize it with normal
Western
people
standard.
like our staff, hospital staff. We tried to get another 100 people we took and we tried to see, because there is no standardization in our Indian population and all. There is a different, there was a problem. And regarding bowel preparation again, this practice was always changing because there is no clear-cut evidence on either side. But when it came to the laparoscopic surgery, most for the left-sided colonic, most people now started preparing because they wanted to deal with a prepared colon, empty colon, but they can deal better. Because of a practical thing, most people are preparing now. Otherwise, previously nobody was preparing in that opener. At one time it was like no preparation. A solid stool is better than a liquid stool. Like concept is there. Regarding residents, I think they should always see whether the patient has features of obstruction, whether the colonoscope was passed before starting on preparation, because otherwise it will make it more problematic. Some of the other things like cardiac evaluation, we have found some difference. Like we started doing stress tests for all major surgeries, and then we found out that we picked up even some of the incidental coronary findings, and if those who requiring intervention, we did intervention, delayed surgery by neoadjuvant treatment and all, and we could achieve a very low, almost near zero cardiac events in the perioperative period. That is one thing we practically tested and tried. So what is your thought on this smoking and all in?
Yeah, I mentioned actually smoking ideally should be stopped at least at least 1 month. At least smoking, nobody can advise not to stop. Anyway, the earlier the better. Smoking and alcohol cessation in that particular study, they say at least 4 weeks prior to any surgery. It's a must. Prior to, because anyway, surgery, abdominal malignancy and all, we can't advise more than 4 weeks because can't waiting list. We can't give more than 4 weeks time for malignancies and all. The longer the better. I mean, 4 weeks is the minimum. Bare minimum. I think Adam will agree with more than that, isn't it? Yeah, 4 weeks minimum.
It was an excellent presentation, Dr. Hari.
Thank you, ma'am.
But it was such a long topic. You have made it into very short. So that was the main problem, because the PGs have found it difficult to follow it up. So the one thing that I have to say is, the main thing that when you do the abdominal surgeries, we are concentrating mainly on the stress response as well as the cardiopulmonary evaluation. So the stress response, as well as then we have to do the ERAS protocol. ERAS protocol mainly deals with what all things that you have mentioned is there. Even then, the pain management as well as early as possible, we have to mobilize the patients to prevent deep vein thrombosis. So these are also should be included in it. So that now the topic is open for the delegates as well as the senior persons, senior sirs that are sitting here.
Hi sir, morning. Excellent presentation. My doubt is, you have already mentioned that the one indicator is serum albumin about the prehabilitation or the pre-nutrition status. So how will you assess your progression or the after the 1 month primordiality pre-operative nourishment? Will you assess repeat the serum albumin, or if it's not improving, will you go for an enteral or parenteral nutrition or something like that?
Yeah, always if you get a patient on the OP, if you find that albumin is low, always if the bowel is okay, again there's a problem, we are dealing with abdominal surgery, there may be the other obstruction, subacute obstruction. If the patient can take orally, and if you have more time to give orally, that's also important. If you're planning surgery, you have 10 days of 1 week time, maybe oral or bowel is not okay, oral is not an option. The best is always oral if you have time. You can give a good protein food, the mentioned as 1.2 to 1.5 gram per day, per kilogram per day. Oral is best. Then after 3 or 4 weeks time, you can reassess again.
How long it will take to reflect the rise in albumin, sir? That's my question.
Albumin level will take a long time. I think a long time to raise. It's not. That's why we need time. 4 weeks, at least 4 weeks time. We need oral albumin level, and IV albumin is useless. We all know IV albumin is useless. So in that case, it's peripheral parenteral nutrition. Patient's bowel is not okay, and we have very short period of time, short time waiting period. parenteral nutrition, peripheral parenteral nutrition, and try to raise the albumin level to somewhat 3.5, which will have a better result than otherwise.
Thank you, sir.
Final question, sir.
No, just to add to what Shabir was said, and to answer to what Bipin was asking, at least in oncology, we have a neoadjuvant concept. So most of our esophageal cancers, most of our gastric cancers, most of our rectal cancers go for a neoadjuvant protocol. So what we do is that we don't just leave it to the medical oncologist or radiation oncologist. We ask the patient to frequently come back to us. During which period we ask them to have a nutritional build-up of a respiratory status, and the cessation of smoking also can be practically implemented. So this neoadjuvant protocols are actually helping us not only in downstream tumor, indirectly is helping us to build up the patient also. So we find that by the time the patient completes the neoadjuvant protocol, all the albumin has been built up, the respiratory status has improved, and so the patient is a better condition to undergo the advanced surgery or major surgery that was planned initially, unless the patient is an obstruction.
Yeah. The point for the younger surgeons, PGs, is always this is a very important point to build up the patient before a major surgery. That's the only point. Thank you.
Can we move on, sir?
Thank you, sir.
Thank you very much, sir. For want of time, with the permission of the chair, we are moving on to the next presentation, next master lecture. May I invite Dr. Tawfiq Ali, please.
Very good morning to each one of you. First of all, I would like to thank the organizing committee for giving me this opportunity to present this topic. So coming on to my topic, window to the abdomen CT scans. So given the constraint of time, I would like to give you the best insight about the CT scan of the abdomen. So what I wish to cover, basically the indications of a CT abdomen, basic terminologies used in a CT abdomen, anatomy of the abdomen and pelvis, various protocols, which are modifications of a CT abdomen. And I'll skip through some of the cases of acute abdomen, blunt trauma abdomen, HPB malignancies, and most importantly, the post-operative abdomen and their complications. And finally, a summary. So indications, as surgeons, you would better know the indications of a CT scan. So to summarize, they are basically used for evaluation of traumatic and non-traumatic abdominal emergencies, evaluation of urinary symptoms, follow-up and diagnosis of oncological patients, post-operative complications, as well as evaluation of abdominal vessels. So there are few terms that are commonly used in describing a CT scan. So they are like attenuation, enhancement, and orientation. So I'd like to give a brief introduction of these terms. So what is an attenuation? Attenuation is basically a black, a white, and different shades of gray in between. So these represent the different tissue in the body as shades of gray in a CT scan. So whatever is less dense will appear as dark, and denser structures will appear as white, and in between structures will be in the shades of gray. So enhancement, as you can see in this diagram here, first one is a non-contrast CT and second is a contrast CT after administration of iodinated IV contrast. So you know the difference. Here you can see a wedge-shaped area of non-enhancement in the upper polar region of the left kidney, which may represent an infarct. And also the normal anatomical descriptors used in the body are also applicable in a CT scan. So I would skip through the different sections of the CT scan, and I'll try to show some of the important structures. Liver, this is a portovenous phase, axial section of the upper abdomen. And here you can see this black thing, as I've already said, is a lung. Since it is a soft tissue window, you are not able to see the lung structures properly, but you are able to see the abdominal soft tissue structures properly. Liver, IVC, and hepatic veins and aorta you can see here. And in the next sections, subsequent sections, you can see better the sections of liver, stomach filled with positive oral contrast, sections of the spleen and diaphragm. And further down, you can see the falciform ligament spleen, portal vein branch, IVC. And further down, you can see the pylorus, small bowels have started appearing. You can see portions of the spleen and the portal vein also. Now you can see the SMV and SMV and their relationship with each other. Hepatic flexure of the colon, pancreatic head, IVC, and portion of the spleen and both kidneys. And further down, you can still see the mesenteric vessels, small bowel loops, the inferiormost portion of the liver, the ascending colon, descending colon, and small bowel loops. Here you can see the mesentery, all the bowel loops, and the kidneys. So same here, bowel loops filled with positive oral contrast. Ileum and IC junction is just visible here, And now the aorta is bifurcated into the iliac vessel, iliac arteries, as well as IVC has further divided into the iliac veins. And now in the pelvis, coming to the pelvis, you can see the gluteal muscles, external iliac arteries, pelvic iliac loops, rectosigmoid. And in males, you can see the prostate further down. And in females, you can see the uterus and both ovaries as depicted here, rectum and bony structures and muscles. So this is a arterial phase. We usually acquire CT scan in multiple phases. Basically, they are the time after which we acquire a CT scan after giving a IV bolus of contrast. So if we do a CT scan in an arterial phase, the arterial structures are better depicted. So they have better enhancement, and arterial structures are all filled with contrast. So as you can see here, the artery, aorta and its branches are particularly well visualized. Parenchyma is not enhanced except for the early nephrographic phase of the kidneys. And now coming to the portovenous phase. So basically this is a CT that is acquired when like after a delay of approximately 50 to 60 seconds, as you can see. So here this is a portovenous phase. Here hepatic veins are not well visualized, but portal vein and all its tributaries are well delineated and are well opacified. So this is a portovenous phase. And further, you can see this is a delayed phase where contrast has washed out from almost all of the vessels, but they are still retained in parenchyma, and more so it is more seen in the pelvic LCL system and in the excretory system, and you can see the contrast that is filled in the urinary bladder. So now reformats. Reformats are basically axial CT scans that are converted into either a sagittal or a coronal projection, where you can see the structures in those projections respectively. So they are not acquired separately. So basically thin sections are acquired in an axial manner, and they are reformatted using computer algorithms. So now I've said the various protocols are there. So just to name a few, they are the CT abdomen modifications include a CT enterography or enteroclysis, where a neutral oral contrast is used to distend the small bowel loops. In enterography, the patient takes them orally, whereas in enteroclysis, and if Recca tube or an NG tube is inserted into the duodenum, and neutral oral contrast is given through the Recca tube. Where in CT colonography, air or more often carbon dioxide is insufflated into the colon, and then a CT scan is taken, and you can reconstruct those images into a virtual colonoscopy, where you can get a fly-through image of the colon, just like an endoscopy, what you will see in an endoscopy, to screen for any polyps or lesions of the colon. And multi-phase CT acquisition, as I've already said, they are basically different times of acquisition of a CT scan after giving an IV bolus of contrast, maybe a single bolus or a dual bolus. And portography, they better delineate the portal system and its collaterals and varices. So coming to a few cases of acute abdomen, blunt trauma abdomen, HPP malignancy, and postoperative, most importantly the postoperative abdomen. 35-year-old female, she came with complaints of 2 weeks of abdominal pain. On examination, there was RI of tenderness and leukocytosis. As you can see here, this was the CT scan after giving oral and rectal positive contrast, as well as IV contrast. In the portovenous phase, in the right iliac fossa region, you can see the dilated appendix with mild periappendiceal fat stranding, as you can see here. And there is mild thickening of the appendiceal wall. And it is not filled with rectal contrast that has been given, positive rectal contrast that has been given. So this is a case of acute appendicitis, which you can make out with the dilated lumen, non-contrast filled lumen, and as well as the periappendiceal inflammatory changes. Now coming to another case, a 30-year-old female, non-thalassemic, complaints of epigastric pain. CT abdomen was done, which showed now you can concentrate on the pancreas. Here you can see an area of non-enhancement, like hypo-enhancement in the pancreas, and there is splenomegaly as she is thalassemic, and no significant other collections are there. So it was amylase and lipase were raised, so it was a case of acute necrotizing pancreatitis, and pain was less than 3 days duration. So now coming to another patient, a 54-year-old male, came with complaints of fever, abdominal pain, and jaundice. So this is the portovenous phase image, which shows there is mild IHBID, intrahepatic biliary radical dilatation here, as you can see here. No significant peripheral ones, but definitely the central radicals are dilated. CBD is mildly dilated. As you can see here, this is the intrapancreatic CBD. It is dilated. And as we go down, it is getting abruptly terminated at the level of a lesion in the pancreatic head. So it is a hypo-enhancing lesion, as in the portovenous phase, there are areas of non-enhancement within the lesion. So it is a hypo-enhancing lesion in the head of pancreas that is causing abrupt narrowing of the CBD at the level of the intrapancreatic CBD. So this was a case of a pancreatic head malignancy. So the same patient in the delayed phase, we could appreciate the lesion better. And also in a multi-phase acquisition, we can better see the relationships with the vessel, which helps in planning surgery as well. So now coming to another case, a 90-year-old male came to us with RTA, blunt trauma abdomen. So this is the arterial phase, which you can make out by seeing the aorta. And this is the lacerations, hepatic lacerations, grade 4 hepatic lacerations seen with perihepatic hematoma, as well as hemoperitoneum, moderate to gross hemoperitoneum. So in arterial phase, you can just see a laceration in the pancreatic body as well. So which is best seen in a portovenous phase image. Here you can see the hepatic lacerations, hemoperitoneum, as well as the pancreatic laceration here. This is the pancreatic laceration, probably involving the MPT. So it was a grade 4 injury of the liver and pancreas. So another case of a 20-year-old male, same blunt trauma abdomen, presented late, 2 weeks after which he had hematomasis, jaundice, and melena. So this was the arterial phase which showed a pseudoaneurysm, intraparenchymal pseudoaneurysm, this globular structure in the arterial phase, which is iso-enhancing, iso-dense with the aorta. So it is a blood-filled sac within the parenchyma and an associated parenchymal hematoma. And this was in turn communicating with the biliary system. So this was the case in the portovenous phase. You can see clots within the CBD as well as the GB. Here you can see the clots within the GB. So this case was later taken up for catheter angiography, which demonstrated that pseudoaneurysm, and a catheter was passed across the neck of the aneurysm into the distal branch, and jailing of the aneurysm sac was done, and he was asymptomatic and discharged on the third day. And now renal injury, similarly they appear as hypodense areas in the normal enhancing parenchyma of the kidney. So this is the case of renal injury, where upper pole shows areas of hypodensity. It was reaching up to the calyces, but there was no active extravasation or contrast leak or pseudoaneurysms. So it was managed conservatively. So now coming to post-op abdomen. So this is a typical post-op case, acquired 3 days after surgery. You can see basal fluid. This is the fluid in the bilateral basis of the lung, causing atelectasis of the basal lung parenchyma. And now you can see multiple drains within the abdomen. Multiple drains are seen, and small pockets of extraluminal air, which is normal in a postoperative abdomen, and also some mesenteric edematous changes and misty mesentery, everything, and small bowel edematous changes. So a normal postoperative abdomen, they include, it is referred to as a smoke of battle. They are basically edematous changes, and there can be mural thickening of bowel loops due to extensive handling, and it doesn't have any clinical consequence. Whereas postoperative wear is common in an open surgery. Postoperative wear is common for up to 7 to 10 days, and for laparoscopic procedure, it is common for up to 2 days. So any air in the abdomen after this set period of time is considered abnormal, and also any pocket of air in the retroperitoneum is considered abnormal. So they could be due to duodenal or rectoseptal perforation, retroperitoneal infection, or any iatrogeny, ERCP, or endoscopy related injuries. So a wet patients are those patients that have comorbidities like cardiac or renal failure, have a tendency for generalized fluid retention. They can have bilateral pleural effusions, common low volume ascites, subcutaneous edema, edematous mesenteric fat, and a small expected increase in volume of the pericardial fluid. So basal pulmonary ectasis, as I've already shown you, it is common in the postoperative period, and some findings they tend to confuse in the postoperative setting, like if a pre-existing mesenteric panniculitis versus if it is a postoperative inflammatory process. So to differentiate that, there are some findings here. In this case, in the first case, you can see a perivascular halo, like a clearing around the fat just adjacent to the vessels. So that is more commonly seen with the panniculitis, whereas in postoperative inflammatory processes are diffuse misty-like mesentery appearance. And some surgical materials are left behind, like a hemostatic agent. They can mimic an abscess. So how to differentiate? They don't enhance. They have motile foci of air, and clinical history or surgical details would help you better. So this was a case of open abdominal aortic aneurysm repair, where a hemostatic agent was left around the aorta. and you can see motile foci of air around it.
Dr. Taufik, can you, because of lack of time, can you just...
So now coming to abnormal postoperative abdominals like peritonitis, some fluid collections or abscesses may be there. In abscesses, they cause mass effect, whereas collections, they are tend to localized in the anatomical spaces. So now coming to obstruction, they can be small bowel obstruction where there is a transition point, and small bowel fecus sign may be there where fecalization of contents within the small bowel is there, and any changes of any ischemic bowel like mesenteric gas or portal venous gas may be there. If it is ileus, there is no transition point as you can see in this abdomen here, but usually the distal colon is collapsed and no transition. In large bowel obstruction, most commonly it is a less common event, whereas the perforation chance is more in the cecum, and dilatation may reach up to 10 to 12 mm. This is a case of extensive large bowel dilatation with mural pockets of air. Pseudo obstruction is where there is a colonic obstruction without any transition point. Here also there is a risk of perforation where cecum is the more common side. Post-operative iatrogenic drain placements may cause injuries. Here in this case, there was an elevated left hemidiaphragm and the drain was placed inadvertently in the colon through the spleen. So this was an intraoperative injury of ureteric injury. So Gossypima textiloma is not an expected diagnosis, and it may remain sterile, but if it is infected, it can form abscess, and metals and plastics also can be found. So take-home message. Adequate clinical history is a must for a tailored CT protocol, and familiarity with the CT terminology helps in effective communication with the radiologist. And in the post-operative setting, adequate surgical details will help in better radiological depiction and description. Thank you.
Thank you very much for a good presentation. Tried to cover a lot of topics. It's jammed. I'll just have one or two questions before we wind up.
Can you a little bit elaborate on triphasic CT?
Yeah. So triphasic CT is basically a multi-phase CT acquisition where we get a non-contrast CT first and then an arterial phase, typically an early and a late arterial phase if feasible is taken, and then a portovenous phase and a delayed phase. Basically they are used to characterize lesions like hepatic lesions or renal lesions to see the different enhancement patterns in arterial phase and portovenous phase where we can differentiate different types of lesions and can you can reach a probable diagnosis from the radiology itself.
We need to close because of the lack of time, particularly the organizers have given me request not to proceed further. On behalf of the Association of Surgeons of India, I particularly would like to thank both the people who have presented and Madam particularly for coming and gracing the occasion. Thank you, Madam. We'll close the session.
Thank you very much, sir. Move on quickly to the next session, and may I please invite the next set of examiners and the chairperson for the next session, Dr. K.C. Soman, Dr. Sajid Kumar, Dr. Ranjan, and the chairperson, Dr. Mohammed Ismail, also onto the dais, please. Dr. Osam Hussain and Dr. Shensi Savio will be presenting the first case, ventral hernia. Once again, may I please request the presenters to stick to time? We're already short of time. Thank you.
Can start your presentation without any delay.
Good morning, teachers and delegates. Myself, Dr. Shensi Savio and Dr. Osam Hussain from Amla Institute of Medical Sciences are here to present a case on ventral hernia. Mr. D, a 68-year-old male patient who is a retired bank employee, came with complaints of swelling above the umbilicus for past 30 years, with the recent increase in size of the swelling for past 6 months duration, and pain over the swelling for past 2 months duration. Coming to history of present illness, the patient was apparently normal 30 years back, and he noticed a swelling above the umbilicus, which was initially small in size, with recent history of increase in size of the swelling for past 6 months duration. The size of the swelling increased on coughing, straining, and lifting weights. The size of the swelling decreases on lying down position. There is no history of fever, vomiting, or constipation. There is no history of chronic cough or smoking. There is no history of incomplete voiding of urine or frequent micturition. Coming to past history, he is a known case of hypertension for past 8 years and he is on antihypertensives. There is no history of any surgeries in the past. Coming to personal history, he is a non-vegetarian bedite with good appetite and adequate sleep, with regular bowel and bladder habits, with no addictions.
Coming to the examination part, the patient was examined and he was conscious, well oriented to time, place, and person. He was moderately built and nourished. There was no pallor, icterus, cyanosis, clubbing, or pitting pedal edema. On vital examination, the pulse rate was 88 per minute and the blood pressure was 140/80, measured on right upper limb in supine position, and his respiratory rate was 15 per minute. It was abdominothoracic and he was febrile. Coming to the local examination, he was examined in a well-lit room after taking adequate exposure and taking consent. And on inspection, there was an oval-shaped swelling of size 5 × 4 cm over the epigastrium, extending approximately 5 cm below the xiphisternum to 2 cm above the umbilicus. There was fullness of the epigastric region, and there was cough impulse. And the skin over the swelling were normal. There was another swelling of 2 × 2 cm in the umbilicus, and the umbilicus were flat, and the cough impulse were present. Coming to the palpation, there was a swelling of size 5 × 4 cm, 6 cm below the xiphisternum and 2 cm above the umbilicus in the midline, and the consistency was doughy, and there was expansive cough impulse, and the swelling became more prominent on raising head and leg, and the swelling was completely reducible manually, and there was a defect of size 3 finger breadth was noted in the midline. On percussion, there was normal resonant not heard, and on auscultation, there was normal bowel sound. And the other system examination. Coming to the examination of the rest of the abdomen, there was soft, non-tender, no masses were palpable, and there was bowel sound heard. And CVS examination, S1, S2 were heard normally, and there was no murmurs. And the respiratory system, normal vesicular breath sound were heard, and no added sound. And central nervous system examination, higher mental functions were normal, and there was no focal neurological deficit. Summarizing the case, he was a 68-year-old male patient, non-case of hypertension for the past 8 years, now presented with complaints of swelling over the epigastrium for 30 years with a recent increase in size of the swelling for past 6 months duration and pain of the swelling for past 2 months duration. On examination, there was a manually reducible swelling of size 5 × 4 cm with expansive cough impulse present over the epigastrium, and the another swelling of size 2 × 2 cm noted in the umbilicus with cough impulse with no signs of irreducibility and intestinal obstruction. Our provisional diagnosis is an reducible uncomplicated epigastric and umbilical hernia with preperitoneal fat or omentum as content. Thank you.
This swelling can be easily diagnosed, but do you offer any differential diagnosis for this swelling?
So there was expansive cough impulse and it was reducible. So our first diagnosis will be a hernia, and it could be an abscess.
No, this is a
lipoma.
Yes, lipoma could be
Lipoma.
Could be a differential diagnosis provided you don't identify any defect. The thing is, early epigastric hernia may not show any evidence of impulse on coughing. Why?
Because a small defect.
It's a small defect, yes, and there is protrusion of the preperitoneal fat. That will be presenting as a swelling. So that swelling as such do not communicate with the peritoneal cavity, so you don't get any. Yes, in those situations you may even think of any subcutaneous nodule, including a lymph node, even though if lymph nodes in the epigastric cavity is not very common thing. So here the diagnosis is not difficult because the evidence of hernia is a swelling with impulse on coughing. And here you have got two swellings, one in the epigastrium, other in the
umbilicus.
Yes. So what are the names of the swelling which appear in the midline cord usually? can have multiple swellings in the epigastric region. What is the reason? Sometimes it can be multiple. Here you have got a swelling in the linea alba, another in the umbilical region. And sometimes you may have multiple defects in the linea alba.
Linea.
What is the reason for this?
A reason for multiple defects in linear.
Any predisposing factors for this epigastric hernias?
Because previous surgery can predispose to multiple.
Then it will become an incision hernia,
Incisional
not
hernia.
an epigastric.
Then obesity.
Obesity is. What is
Old
the
age.
basic reason for this swelling becoming larger and larger?
Increase in intra-abdominal pressure.
Is rise in the
Intra-abdominal
intra-abdominal
pressure.
pressure. And why this linea alba is prone for this kind of multiple defects?
Laxity.
How is the linea alba formed?
Striations. How many?
The aponeurosis of the external oblique muscle, both join in the midline to form the
The
linea.
aponeurosis of the external oblique aponeurosis contribute to the formation of linea alba.
Well,
So what are there on either side of the linea alba?
we have rectus
Rectus
abdominis
sheath.
muscle. Rectus
Yes.
sheath.
Yes. How is the rectus sheath? How is the linea alba formed from the rectus sheath?
There is anterior rectus sheath. The rectus abdominis covered by anterior rectus sheath and posterior rectus sheath.
So you have got anterior rectus
Rectus
sheath,
sheath and posterior
rectus
rectus
sheath,
sheath.
extends, and form a thick line in the middle. That's what's called linea means line, alba means white, a white line in the middle. And the actual formation of the linea alba is the fibers from the both rectus sheath interdecussate like this and form a strong line in the midline. So when you have got interdecussating fibers like this, there's a chance for a hole formation in between the fibers. So that's why this linea alba is prone for multiple defects and later on presenting as
hernias.
Epigastric. So the theory is probably the increased intra-abdominal pressure, which persists over a longer time, can ultimately give rise to this. And also congenitally also you can have certain weak areas, and you may develop, patient may develop a solitary epigastric hernia. So this, since these hernias usually start as a peritoneal fat protruding through the defect, so they are generally called fatty hernia of the
Linea alba.
Yes.
How do you proceed?
First of all, we go for the routine investigations, go for CBC and all other routine investigation. And we can, even if clinically we can diagnose the patient, we can go for a USG abdomen to know the exact contents of the hernia.
Anything specifically you are looking in the investigation of a patient recently developing an umbilical hernia. This umbilical hernia has been detected recently.
Mm.
It was not there.
It's
All
only
the-
detected clinically. The patient doesn't.
Patient
doesn't complain.
Complain. Okay. So you have detected. Is it any reason you want to attribute or you want to evaluate by investigation?
Do an
USG abdomen.
Okay,
USG.
definitely. You said you want to know the diagnosis by ultrasound, the defect size and other thing has been
Defect
assessed.
size, mm.
Any other defect in the midline as well.
So-
You may have another defect also, then need to be visible on your examination. That also has to be noticed. Apart from that, anything else you know? You know?
Whether there is any ascites or
Okay, definitely. That's one reason. An old man definitely you have to look for any newer pathology because it may be a tip of an iceberg of some problem that's happening inside. Maybe having some other major problem there that may bringing the patients may be attributed to that. That also has to be kept in your mind. That's the most important point. Like the, liver dysfunction, even malignancy may be the reason. Some other malignancy may be happening there because of that. Maybe definitely you have to have an eye on that problem also there. And what are the other things specifically what you are looking in the ultrasound regarding the hernia? What is your interest? So as a treating personality, what is your interest in assessing or reading the ultrasound?
Any signs of strangulation or
Okay, definitely it's a complicated and complicated hernia. Then
Content of the hernia to know
content of the hernia.
to know the size of the defect.
Size
And size of the
size.
defect.
What is the importance of size?
So that we can plan the size of the mesh to be used if you know what is the size of the defect, and whether if it is less than 2 centimeter we can go for a primary closure, otherwise we will have to use a mesh. So we have to know the exact size of the defect, and the number of defects to plan the surgery or
There are
In
two
the
swellings.
ultrasound, if you
There are two swellings, an epigastric swelling and a recently developed umbilical swelling. So one is of a long history and other is of a short history. That's why Sir asked, what are the other investigations you look, because recently he is developing an umbilical swelling also. Is it? So it is actually really two swellings, not single swelling.
not a single swelling.
in the ultrasound you find the reported as ascites.
Yeah.
So how will you change your treatment of the hernia repair?
So first, we have to know what is the cause for ascites and treat the primary pathology, and after that, can go.
Suppose if it reported as the liver is showing features of cirrhosis liver, the patient is having a chronic liver disease. So patient with a chronic liver disease with umbilical hernia or epigastric hernia, whether is there any change in the treatment of a normal person? Or what will be the problems if you treat an umbilical hernia repair in a CLD patient?
Chance for recurrence, mesh failure can occur.
Yeah.
Any precautions will you take? Because
So,
will you operate on all patients, or you will take on to some set of patients? And if you are operating, any precautions will you take?
Usually, you have to control the ascites, because if the ascites is there will be a leak of the fluid and the chance of the infection, and of course the recurrence is the more. So only symptomatic hernias in CLD patient, and if you want to operate, then you have to control the ascites medically. Then only you can operate, and you have to keep that ascitic fluid minimal. Okay. What will be your treatment in this patient? How you are going to proceed? Whether you will decide on an open surgery or a laparoscopic surgery, or what? What is the
First option would be open mesh repair. We can.
Do you have the ultrasound report with
sir.
you? No.
No, sir.
No investigation reports with you.
No, sir, not done.
Okay.
tension-free repair. So the treatment is tension-free repair. It can be done either by open or by laparoscopic method. And in this patient, we can go for laparoscopic surgery. We can offer both to the patient, and considering the age, comorbidities and all, we can plan the surgery as such. If laparoscopy will be better in this patient because of less pain, post-operative pain will be less, and better cosmetic outcome. So we can.
What are the laparoscopic procedures for the ventral hernia repair? What all the names it's described? What all the, and which all situations you're going to have a very good talk next. After that, you must have. What is your idea about the ventral hernia repairs laparoscopically?
IPOM.
IPOM, intraperitoneal only mission. Then there is transverse abdominis release, TAR.
Louder.
There is IPOM, intraperitoneal.
IPOM is one option.
Then TAR, transverse abdominis release.
What is central lesion? There's a lesion. You are talking about a lesion in the center part.
midline.
You have a two defect there.
TAP, we can.
It is IPOM, IPOM plus.
IPOM plus.
You know what is IPOM, IPOM plus, and what is AWR? This is all the different surgeries for different indications. Depends on the size of the defect. And what is the other investigations you would like to do if it's a hernia is a large hernia, or if it is a complicated hernia? Would you like to do a CT scan abdomen?
Yeah, we can.
What is the advantage of a CT scan abdomen over ultrasound?
In ventral hernia.
In ventral hernia.
In large hernias, there might be loss of domain.
What do you mean by that? What is your concept of domain loss?
There is in long-standing hernia, the abdominal contents will be outside the peritoneal space. So, if we are trying to keep this abdominal contents back into the abdomen in a single setting, that will lead to the raise in intra-abdominal pressure that can cause abdominal compartment syndrome.
Yeah.
So, to know whether this hernia can be accommodated.
So when you suspect a abdominal compression, compartment syndrome post-operatively, there is an index,
Anticipation. How do you anticipate?
Which all patients you can anticipate. That depends on the CT scan report.
Calculate. How do you calculate the domain loss? Any calculation knowing? The volume of the hernia divided by the volume of the abdomen. And if it's more than 20%, definitely this is a serious issue. So
more than 25% if the volume of the hernial sac is more than 25% of the volume of the abdomen, then these type of the patients you can expect a post-operative compartment syndrome. And I think the time is
okay.
There are, the next question is what are the things you can do pre-operatively
there's a
to
domain
reduce
loss.
the compartment syndrome?
What are the preparations you may take? Precautions before procedures like the Hydra mentioned. Okay.
The time is over.
Thank you.
Thank you, sir.
Thank you so much. Congratulations, Dr. Osam Hussain and Dr. Shensi Savio. The next topic presentation. To chair the session, we have Dr. Ismail also, along with the examiners on stage. It will be made by Dr. Partha Sarthi. May I please invite you onto the dais, sir? Dr. Partha Sarthi, Senior Consultant, GEM Hospital, Coimbatore.
We know that the treatment of ventral hernia repair has changed a lot during last few years. And Dr. Parthasarathi, he is a pioneer in the repair of the ventral hernia by AWR and so many other new techniques. And it is our pleasure to get him here today for the talk. Thank you, Parthasarathi, for the talk.
Good morning to all. I'd like to thank the organizing committee of this rounds 23, particularly Dr. Ismail and Dr. Santosh sir and Dr. Other senior faculties and Dr. Varghese to giving me this opportunity. And today my topic allotted to me is road to repair, the tailored approach of ventral hernia management. So there is a lot of changes. When we started way back in 1997, first ventral hernia we started laparoscopically. And then from 2003 onwards, all our hernias we treated by laparoscopic method. So coming to the small introduction, the hernia repair is most commonly done worldwide. In India, if we take majority of the patients are laborers and farmers. So the open hernia took longer recovery time, high morbidity, pain. And so these are all the things leads to the application of laparoscopic hernia in India. So initially it was done by 1993 by Professor Leblanc, a minimally invasive way, and it incorporates Pascal's principles of hydrostatics. So a lot of changes in management of ventral hernia from the beginning. So nowadays is more trends towards the abdominal wall reconstruction from IPOM to E-tip. The concept is changing. And in case of complex abdominal wall hernias, initially we do anterior component, now we are doing a posterior component along with the transverse abdominis release, otherwise called TOR. So for the basic thing, these are all the placement of the mesh position during ventral hernia repair. In open surgery, we are doing with the onlay. So this is the onlay mesh just over the anterectus sheath. And next comes inlay. So no, it is not recommended basically. It is a bridging the defect is not recommended. The sublay is retrorectus between the rectus muscle and rectus sheath. That is what we are doing it in a E-tip. And that underlay preperitoneal is tip and tap, just above the level of peritoneum. And what we are doing is underlay intraperitoneal, that is IPOM. So IPOM correct terminology is intraperitoneal placement of mesh, otherwise called underlay intraperitoneal. All of you know about the CHS classification from midline hernias M to M5 from subxiphoid to suprapubic, lateral hernias subcostal to lumbar L1 to L3, L4. So this is a known classification and most of the surgeons are following this classification for ventral hernias. This is another new classification like a TNM like classification, and here it's the HPW, it's a hernia size, comorbidities and wound status. They are making in a stage. Hernia also is considered different separate specialty. Like a TNM, they are making a stage 1, 2, 3, 4. And what is the indication of laparoscopic surgery? Here it is, you can observe here it is width is 4 centimeter, height is 10 centimeter. So that is the indication of laparoscopic hernia repair. If it is more than 4 or more than 10, you may require some additional compartment release. Otherwise, no, we can go for an open surgery. So this is one of our article, Indian surgeon Sarfaraz article, and how to choose the procedure, because a lot of procedure is there. And anything is up to 5 centimeter, you can go for IPOM plus, that is the standard one. And if it is even up to 6 centimeter, you can go with the obese patient. And if it is more than 5 centimeter with divarication or up to 12 centimeter, we can go for E-tip and TOR. And if it is more than 12 centimeter, you can go for open TOR. So these are all the standard way of doing, selecting the cases. And what we are following in GEM is up to 2 to 5 centimeter, we go for IPOM or E-tip. Now it is 50-50 like but IPOM has a big role compared with E-tip. And if it is obese patient, we can go IPOM plus up to 6 centimeter. And if it is more than 6 and 5 centimeter defect, then we can combine anterior component separation in IPOM. That is a release of external oblique aponeurosis from the muscle. Then if it is more than 10 centimeter, up to 10 centimeter, we can go for E-tip plus or minus TOR, depends on the patient status. And if it is more than 10 or 12 centimeter, we can go for open Reeves-Topa method with TOR. So for that, we have to prepare the patient with the Botox injection and progressive pneumoperitoneum. So I like to show we'll discuss about the IPOM plus. And here the technique, standard technique from almost 20-25 years, people are using it, shorter learning curve. And this is the first step to AWR. So it is easier. Recurrence is less, seroma formation is less, improved abnormal function, and large mesh can be placed, divarication also can be corrected. And we follow in GEM technique is we defect closer, we remove the sac, we close the defect, then we do the midline approximation, then we place the mesh. That's why it's called IPOM plus. And we published a report in way back in 2007. So these are all the port position for M1, M2 hernia, that is upper midline hernias or epigastric hernias, lateral port. And if it is a M3 and M4, we can go for the port in the upper midline. And if it is a suprapubic, all this port little down. These are all the lateral hernias. Opposite to the hernia, you can make 3 port and then you can work. I have a video, you can see this patient had a lower midline scar with the hernia here. And I'm creating the pneumo. Patient is in supine. I'm standing on the head end of the patient. My camera surgeon on left side of me. And on two subcostal region, working port has been made. And this will give a good angle, 60 to 70 degree angle. First thing is the adhesolysis. If it is a bowel adhesion is there, we have to use only the scissor without cautery. And if it is a momentum, you can use any energy device. And I'm removing the sac. All the cases sac to be removed, then only the closure will be effective. So the sac, you can see the thick sac, so it will reduce the serum of formation. And we have to give around 5 to 10 centimeter down clear, mesh surrounding placement, so that I mobilize the bladder. This patient uterus was adherent, I mobilized it. And then we started closure of the defect. You can appreciate I'll take only the needle, all the thread is outside. I'll take the needle and then I started closing the defect. And you can appreciate I'm using only one hand, so it is intracorporeal suturing. My left hand is pressing the abdominal wall so that I can able to take the transfer stitch. You can appreciate transfer stitch. This is the 50 mm needle 1 ethylene loop. That is a polyamide loop. And it has been closed completely like what we do in open method. And once you reach the upper end of the defect, then I can come down because the thread is outside in the lower end of the defect. So the completely defect closure has been done. The thread, needle has taken down. The thread has been taken. The same puncture, what the way it is come, the same puncture I taken, and then I made a knot subcutaneously. So the knot will not be visible or palpable. And then standard size, the composite mesh, any mesh, composite mesh is, you can use any company composite mesh. This is 20 by 15 mesh because we need to cover 8 centimeter all around. So the 20 by 60 meshes I am taking, and I hydrate the mesh before taking it. This is a collagen film with the polyester cover mesh with the collagen film covering. And standard recommendation is 3 to 4 transfacial suture. I made 1 transfacial suture in the lower border and the upper border 3 transfacial suture. And you can apply any anchor or taker, and our preference is intracorporeal suturing. And so we take a multiple suture. It has in a 4 row of suture, around 14 to 15 number of sutures will be there in 4 rows. So this is the way we do in a standard way of doing IPOM plus hernia repair. And in case of large defect, it should be combined with the anterior component separation. For that, we have to release the external oblique aponeurosis. And we do in anterior component in endoscopic method, that is a laparoscopic method. This is a video of IPOM plus with the right side anterior component. So you can appreciate the CT. It's a very large defect, almost 10 to 12 centimeter. So laparoscopic view, the position and port is same like in the previous case. You can see 3 ports in the epigastrium and on either side working. It's a very huge one. Again, standing on the head end and then operating the surgery. So initially, adhesolysis, this patient had a large bowel adhesions and omental adhesions. Second thing is sac excision. And as I told you, previous case is a smaller sac, and this case is a bigger one, even though we have to take out the sac completely, that is mandatory. So you can appreciate the entire sac is being taken. And once you've taken down in the edge, then the center part is very easier. Start from the edge of the sac and then come to the center. So you can appreciate, the entire sac has been removed, and then I have to mobilize the bladder so that the mesh can go up to the pubic bone level. Since it is a huge defect, I want to place the mesh. So after excision of the sac, you can appreciate the trans-elimination. I keep the mesh. So now it is, I've tried to, even externally, I'm not able to approximate. So I'm taking a 11 mm OptiView trocar with a 0 degree 10 mm telescope. I made a space between the subcutaneous and the anterectus sheath. That is a scola plane, and the trocar is lateral to the semilunaris line. And another, I see this is the plane I entered, and then this is another 5 mm trocar. So here I'm creating the plane between the subcutaneous tissue and the anterectus sheath on the lateral side, lateral to the semilunaris line. So now I started releasing the external. This is the external oblique aponeurosis. This is the muscle. I'm releasing it. Down you can see the internal oblique muscle. And I can go up to the internal, inguinal ligament, here up to the subcostal level. So we can get around 6 to 8 centimeter distance If it is not adequate, you can go for a other side also. And this patient, I have done only one side and anterior component separation. I started suturing the defect. I placed the drain, and even though it's a big defect, this one side release it will be helpful, and you can appreciate I can able to close this entire defect with the intracorporeal suturing without any difficulties. I used to keep the pressure 8, then after that I increase the pressure during placement of the mesh. And this case I place around 25 into 20 centimeter mesh. And the mesh is being sutured to the Cooper's ligament. This is the right Cooper suture, and this is the left Cooper suture. This is the one is preventing the lower recurrence. So 25 by 20 mesh is adequate coverage is there. You can see this entire transfacial suturing, and then I am applying a takers. A large mesh taker application is easier, and then I suture also. So this is the way we manage the complex hernias like with the anterior component separation. So what about in a divarication of recti? And the same way, here it is a loss of domain may be there. Sorry, very patient associated with the back pain. It's a common after pregnancy. Disc injury is also there. So again, same technique. I'm just making a fast forward. So here you can appreciate the transillumination, that is the thinned out rectus muscle. Just I'm measuring by inserting the LP needle, just measuring the distance, and then we can started mobilizing the bladder. And here there is no defect, maybe associated with smaller defect. We have to do the plication suture. This is our technique by Chief Palnivelu sir, and you can appreciate I'm taking starting from left side to right side, then from right side to left side I'm going like a plication suture. Once I tighten the suture, you can appreciate the thinned out linea become like a vertical band like and then coming together. So it is like 2 to 3 centimeter distance, and so that it will bring the medialization of the rectus muscle. You can appreciate with the 12 millimeter pressure, the abdomen is not much distended. This is one of the technically challenging one. And once you practice the intracorporeal suturing, you can able to do it. And it's no need for abdominoplasty or any other method. So this is one of the ideal method for plication of recti along with the divarication of recti with hernia. Now you can see it is the flat abdomen. And same way, this is say even with the pressure, it is not bulged out with the 14 millimeter pressure. And same way we can suture the mesh. So a lot of patients now presented with the divarication recti along with the hernia. If we not correct the divarication recti, the patient will go for a recurrent, recurrent hernia will be there. So you have to correct the divarication, then we have to place the mesh. So I skip the recurrent hernia, and the E-tap is the excellent technique. Sorry, can I take 2 minutes, sir? Just show the video. Yeah, okay. For large complex hernias, we can go for a E-tap. And also I'll directly go for video, and this is an indication of selective indication of E-tap is recurrence, suprapubic and subsiphoid hernia, larger defect, lateral wall defect. And you can see here we entered into the optic view trocar. Here I am going between the rectus muscle and rectus sheath. Above is the rectus muscle, below is the rectus sheath. And we are dissecting with the scope itself. So after that, we made a 3 trocar in the linear semilunars level on the left lumbar and left iliac fossa level, so that we are creating the space. Now you can appreciate this. I am working from this trocar, creating the space between the rectus muscle and the rectus sheath. You can see the rectus muscle above, rectus sheath down. So now I am doing the midline cross. I am doing the midline cross. I entered this left right sublay space, that is the right rectus muscle, right rectus sheath. So the right sublay space is being entered. So without Nemo, we entered the right sublay space. So I create another port. So now I'm standing here, and then I'm working in the head end of the patient. So I'm going down. So here the anatomical plane is getting opened. So this is it's called Volcano sign. So I'm releasing, this is the defect, hernia defect. This is the rectus post rectus sheath on right side, post rectus left side. That is the linea alba above. Both sides is a rectus muscle. and we are creating the space between the rectus muscle and rectus sheath basically. So here after this the linea alba ends here, so both is connected. There's no need to go down till the pubic bone. So now you can appreciate this patient also had a widened rectus linea alba. So I started suturing. Here I am using a different suture. This is the V-lock PPT suture. And again I use only my one hand, single hand. You can appreciate I turn the needle before I taking the stitch. And completely the linea has been sutured. So now anteriorly it is strong. Now I have to suture the post-rectus sheath. Again I am taking a V-lock PP, that is a previously non-absorbable. This is the PDS absorbable suture. We are approximating the both cut edge of the post-rectus sheath, right side post-rectus and the left side post-rectus sheath. So that's been closed completely. Up to what level you divided, you have to suture. Now the entire space is there between the rectus muscle and the rectus sheath. We can place the mesh, and then suturing is optional. We can able to suture. Then I release the Nemo. So the mesh is placed between the rectus muscle and the rectus sheath. So this is the E-tip. In case suppose if we have large defect, you can go for TAR. Just I saw the TAR and then I stopped it, sir. Same way I am entering. This patient got a multiple surgery, and same way I am crossing the midline. So here, even though it is extraperitoneal repair, we can access the intraperitoneal, all the area. So you can see the interperitoneal organs and any adhesions, bowel, omentum, you can remove. And then you can take out the sac. Then you can create the space between the rectus muscle and the rectus sheath. Then place the proline mesh, polypropylene mesh, and then come out. So no need for costly mesh like a composite mesh, and no need to fix the mesh because the entire dissected space was occupied by the mesh. So now it is pubic bone is now covered, and with large defect, I cannot approximate. I started doing a TARS. So this is the way. This is a neurovascular bundle, and this is the post-rectus sheath. So this is the linea semilunaris. This is another neurovascular bundle. This is called lamp post sign. So this is the attachment of the TA muscle. TA muscle is insertion of the TA muscle to the post-rectus sheath. I started dividing the TA muscle. What you are seeing is the postal layer of the transversalis fascia. So again I am continuing division of TA muscle, that is called TAR. So this is the neurovascular bundle is preserved. Now I am going down. Again another neurovascular bundle in the view. So it is a arcuate line. So now it's only few fiber is there. So it has been divided. So completely done TAR from top to bottom, from above to down, I down. So again it is not able to approximate. So I have to do the PCS, posterior component separation. I am extending TAR to the superior side, that is a caudal cranial side. See, now it is getting. So I am releasing bottom to TAR from the left side. Then I started suturing the defect. Then I placed the mesh. So this is one of the very upcoming surgery. Any large defect you can use this T-tip TAR, and it's a time consuming. Learning curve is long learning curve. Once you are well versed with the TEP surgery, then you can go for this TAR very easily. Then after closing, I keep the mesh and then I come out. So this is the large mesh, like this I keep and then I'll come out. And some of the case I can do triple P, that is a placement of the this one catheter, and then I go for open reef stopper, and then large mesh can be placed. This is one of the case, very large hernia, and you can see the patient underwent 4 surgeries including colostomy repair, and he cannot able to lie down straight because of the entire, even the CT scan shows the kidney is outside. So it is totally loss of domain. And in this case, I have done open reef stop and TAR. The patient is doing good, fine. So these are all the new procedure: Tom, Lira, and Emilos and Scola. And with this, I'll finish. Skilled hernia surgeon, they should know the entire knowledge of anatomy of abdominal wall and groin, expertise in suturing, and experience in open and laparoscopic surgery, and robotic also it is coming in the way, but there is no extra benefit. So with this I will finish. Thank you so much.
Thank you, Partha. Excellent presentation as usual. And as one or two questions we can entertain.
Sir, excellent presentation. My one doubt is regarding the last ETEP TAR presentation. So you have removed the sac. There is a new technique of keeping the peritoneal flap with the PRS so that we can avoid unnecessary TAR. So what your take on that?
Yeah, we have a big sac in the midline defect, particularly that we can follow this, or lateral defect, right iliac fossa defect. Then we can remove, we can keep the sac along with the postector sheath. We can utilize the sac to close it. But as far as possible, I don't do this because the TAR is better than this one. And if it is a large defect, thick sac, then if you try to preserve the sac, then it will be utilized to cover the defect in the PRS so that TAR can be avoided.
Thank you.
I'm doing it that also, yeah.
Even sometimes the omentum can be stitched between the defects.
Yeah, that is
Some
people are
surgeons.
doing recently, but I'm not for
Yeah,
that,
yeah.
sir. Yeah, okay.
Thank you, Partha Sarathy,
Thank you,
for
sir.
the excellent
Thank you. Sorry, I
presentation.
took
Thank you.
2
Thank you
minutes
very much.
extra. Thank you.
I think it's a time for inauguration and we will close the session. Thank you.
Thank you, chairpersons and the examiners of this session. Thank you, Dr. Parthasarathy. May I request the dignitaries to kindly take the seats off the dais, please. Thank you. We'll be preparing for the panel discussion next. In the meanwhile, the same announcements once again. All the posters are exhibited in the hall behind the seats. Postgraduates may please take photographs from the site of the poster presentation selected for the competition will be announced shortly. This competition will take place at the ground floor. Details will be announced shortly. Algorithms are on display outside the auditorium. PGs are kindly requested to visit them during the breaks. We have a hands-on session today for the venous Doppler and the ultrasound abdomen for the PG residents during lunchtime. All the residents are kindly advised to check if your names are among the selected candidates for the sessions and kindly attend the sessions on time. An exhibition of paintings by Dr. Sijin is on display outside the auditorium. It's a real feast for one's eye. Make sure you do not miss this. The list of students selected for the ultrasound abdomen and venous Dopplers and lunch with the teachers is being displayed on the TV screens at the back of the auditorium. I'd like to remind you all that the PGs have to take a look at the list and make sure your names are there as selected candidates. Thank you. We'll be just preparing for the panel discussions next. We have the panel discussion. May I please invite the panelists onto the dais. Dr. Srijan, Medical Superintendent GMC Calicut, Advocate K.N.A. Kader, Legal Consultant, Professional Protection Scheme, IMA, Dr. S. Sri Kumar, Professor and Head of Department of General Surgery, GMC Kannur, and Dr. Hitesh Shankar, Head of Department, Forensic Medicine, GMC Manjeri. Ladies and gentlemen, very important and often neglected session. This session will be moderated by none other than Dr. Santosh J. Abraham, a past national president of ASI. May I please kindly request you all to take your seats. PG students in particular, kindly pay attention. Thank you.
Can you just switch that up? No projections. We'll start the projection later on.
Over to you, sir, the moderator.
Yeah, thank you. I would request all the participant delegates to take their seats, particularly those who are standing in the back. Can you just please come over and take your seat? Very good morning to all of you. Thank you very much for the organizers and the team of ASI office bearers for requesting me to moderate this session. My thanks to all the delegates. May I have the pleasure in introducing the panelists. We have two people from within and two people from outside surgical fraternity. And for ease, I will introduce people from within. Dr. Srijayan needs no introduction. He is the current chairman of the chapter, professor of surgery with long years of experience, and currently adding administrative post as the superintendent, dealing with many public and their grievances, and the host of staff who also adds to its burden. The second person is Professor Sri Kumar. He is heading the Department of Surgery at Kannur Medical College. Again, a man with long teaching experience. And on behalf of all of you, let me extend a warm welcome to two of these people who are members of the ASI. The other two members require a formal introduction and a more profound welcome because you both are from one from outside the profession and one within the profession, though a different specialty. Dr. Hidesh Shankar, he is professor of forensic medicine and head of the department at Government Medical College, Mancheri. And he is a police surgeon by default, having been into the position of head department of forensic medicine in medical college. He is a well-known figure in medical jurisprudence, criminology, and ASI expresses its sincere gratitude to you, sir, for gracing this occasion amidst your busy schedule. The last person, but the most important person here, is Advocate K.N.A. Khadar, who was the former MLA of Legislative Assembly of Kerala and currently a practicing advocate and appears before the court for many IMA-related cases. And needless to say that surgeons are part of IMA too. And he is appearing for many cases. Thank you, sir, for gracing this occasion. We have been given an hour to discuss some of the key issues related to the legal aspects of surgical practice. Both professions being very long drawn out and 4 years, 5 years, 6 years for training and then post-graduation, it's difficult to cover everything combined together in 1 hour. We'll just touch upon few areas in 45 minutes and leave the 15 minutes for discussion with questions from the audience. As you continue to practice surgery, any procedure for that matter, you are bound to have unpleasant patients because the patient's expectation will be much different from what we can offer to them in terms of diseases. So it's again very difficult to discuss all these things together. So we took up a few areas which can be of, importance to us. So let's start with some discussion on consent. One of the key issues which is faced by surgeons and those who are doing procedures are confronted with consents. So let me just start with Professor Srijayan. How do you say what is consent, or what's in your mind, what is consent?
Generally, when a patient comes to us in the consultation room, we are bound to examine the patient and we get an implied consent that we can do certain things. The patient is coming for a problem, so we are supposed to examine the patient, the history-taking clinical examination, including auscultation. So auscultation can be a litigation sometimes, because when the patient feels that the stethoscope is kept on the chest and this clinician has done something, so such things can also happen, but that is also implied, and the clinician is supposed to do all those examinations. And in a different scenario, to do or to perform a procedure, again, we need different types of consents. And can be the most important one is informed consent. We have to explain everything, that is, what is the condition of the patient, what are the investigations which we are going to do, and what are the procedures which we are going to do, and the complications, the pros and cons, and what goes wrong if we don't do the procedure, or if the patient is not willing for the procedure, and then what are the alternative methods. Everything we have to explain and get a consent.
Thank you, Dr. Srijan. Srikumar, do you have anything more to add to this?
I think the consent should not be a one-way process. There should be a healthy discussion between the patient, relatives, and the treating team about the pros and cons of the treatment and other options also for treatment. And then only the relatives and the patient should decide and agree upon what we suggest, with the belief that it is for their best interest. Then only it becomes a proper consent.
Thank you, Dr. Srikumar. Coming to Dr. Hitesh, there are two types of consents that has been described, the implied consent and the informed consent. In the parlors of, jurisprudence, would you like to make a mention, redefine this or add something to this? Can you switch on?
Morning, one and all. And as you all know, consent is defined in Indian Contract Act. Actually, if two people agree upon the same thing in the same sense, then it can be consented. That term can be used. But in the medical context, the doctor and the patient are on two different foods. Doctor is a person who knows everything about the disease, and he knows how to treat that patient. He knows everything. What will come, what's the outcome of the treatment, and what happens if he not receiving the treatment. Everything he knows, but the patient knows little. So while taking the consent, you must discuss everything possible with the patient and form an opinion, shared decision-making process, and you have to get the consent from the patient. Then only it can be termed as a informed consent. Thus, while talking about the informed consent, I like to emphasize on one of the judgment from on Apex Court of India, that is in Samuel versus Prabha Manichand case, in which the court described two types of consent: the real consent, which is practicing in United Kingdom, and the informed consent, which is practicing in US. The main difference is that what all things to be discussed with the patient. According to the UK system of this consent, it is a real consent or true consent. That is, adequate information can be divulged to the patient to get the consent. And compared to the other system, where there is necessary information you have to convey. These are the two differences. How we convey the details to the patient and what all information to be given to the patient, it is well discussed in that case. So, apart from the general principle, that is the competency to give the consent and consent without coercion, such things, voluntariness of the consent, everything must be there. But up to what level it should be discussed, up to what level it could be disclosed to the patient, that will be decided by the physician, and after taking the patient into confidence, he has to get the consent.
Thank you, Dr. Hitesh. Can you come down? Dr. Khader, in the parlors when it comes to court, how is the court viewing the consent? Which team member is held liable? Is it the surgeon himself who has to take the consent? can it be taken by his team of doctors, or is it be something which is relegated to nurses, or can it be done by a scribe? These are some of the things which will happen in the court of law.
Yes, I appreciate the explanations of my medical friends. Consent, as they have said, is consensus ad idem, meeting of minds, concurrence of will. Consensus ad idem is the definition given in Contract Act 1872. There must be a consensus ad idem. Same thing, same sense, that's all right. Then as far as the consent is concerned, the patient must be, or the person who is giving consent must be competent. What do you mean by competence? Competence means, first of all, age related. Majority has to be attained. In India, it is 18, age 18. Then he should not be of unsound mind. The other thing, he should not be under the influence of drinks, drugs, or some intoxicating things. So he should be of should not be unsound mind, majority attained. And another thing, as far as in some cases, just like sterilization, etc., it is better to take the consent of the spouse also. Then, if consent is refused by the patient, then informed refusal has to be recorded. That will be safety in the court. Informed refusal has to be recorded. Consent or this medical negligence is actually originated from a very famous case happened in English, UK, that is Bolam's test. That has taken place in 1957. Bolam's case was a case of mental disease. That mental disease patient came to the doctor, and during that period there was no medical cases at all. Medical negligence cases were very rare. At that time, he has consented for the surgery, and electroconvulsive therapy was prescribed. Electroconvulsive therapy has done thrice, and after the third time, an acetabular fracture was occurred. That was a complication of this thing. Manual control was doing. The other expert opinion was, after giving muscle relaxant agents, this can be done. Then this will not happen. But two opinions were there. Muscle relaxants kodukano, ado manual control madhyo. Manual control oru fracture possibility undu. Mattadil death possibility undu. Doctor accepted this first lane, manual control. So he was not negligent. അന്നാണ് ഇത് ഫിക്സ് ചെയ്തത്. എങ്ങനെയാണ് ഇതിൻ്റെ സ്റ്റാൻഡേർഡ്? പിന്നെ ആക്സെപ്റ്റഡ് സ്റ്റാൻഡേർഡ് ആ കാലത്ത് എന്താണോ നിലനിൽക്കുന്നത് ആ സമയത്തുള്ള മെഡിക്കൽ സ്റ്റാൻഡേർഡ് അനുസരിച്ച് റീസണബിൾ കെയർ സ്കിൽ ആൻഡ് കോഷൻ ഉണ്ടായാൽ മതി. ഹൈ സ്കില്ല് ആവശ്യമില്ല, ലോ സ്കില്ലും പോരാ. അപ്പോൾ റീസണബിൾ ആയിരിക്കണം, സ്റ്റാൻഡേർഡ് ആയിരിക്കണം. പിന്നെ കൺസെൻറ്റ്, ആസ് ഫാർ as the consent is concerned, there is no fixed performer for consent. IMA has made a...
I'll come back to that, sir, in a minute. I think Dr.
One thing, in the consent form, the doctor has to be signed. Doctor, his qualification, his
registration number,
everything. Witness must be there. Then patient or consenting person.
I think
that
it is...
can be done by the team member, any member, not only doctor.
Yeah, but the importance of this is possibly because the consent is being given to a surgeon to perform that procedure. Whether under his supervision somebody else performs or not is, it may not be given to the lowest cadre of the team member. So that particular person, the chief of the responsible unit head, probably will have to take the consent. This writing can be done by the scribe. That is what he meant. Am I right, sir?
Whoever may be the writer, but if the senior surgeon has signed it.
Okay, that's
then
what
it
I
is
agree.
owned by.
Yeah. Dr. Hidesh, you wanted to have?
This question, actually, this is not being addressed by any of the verdicts in India. It is not being addressed by any of the verdict. But the thing is that, ഒരു ഹോസ്പിറ്റലാണെങ്കിൽ HOD അല്ലെങ്കിൽ പ്രൊഫസർ ഹൗസ് സർജനെ കൊണ്ട് കൺസെന്റ് എടുപ്പിക്കുന്ന ഒരു രീതി, അല്ലെങ്കിൽ സീനിയർ ഡോക്ടർ ജൂനിയർ ഡോക്ടറെ കൊണ്ട് കൺസെന്റ് എടുപ്പിക്കുന്ന രീതിയൊക്കെ ഇതെല്ലാം. But only the surgeon who is doing the process, he knows what all things going to be done in this case. So the person who knows everything about the patient and everything about the procedure should take the consent.
So, yeah, I think the basic understanding is that the team who is doing this work, who knows about the patient, can have the whole thing, but the final responsibility shall lie with the concerned surgeon who is going to perform that program. So that's the way. I think they have also cleared the fact that anybody above the age of 18 is the person who can give the consent. There was a question of 12 to 18 who has to give the consent, and Mr. Kader has already cleared it, and Dr. Hidesh has supported it.
It is from the parental side.
Yes. So below the age of 18, it is responsible, parents or next.
Or decision-making
Yes, next, yeah, or next of kins who are capable of making the decision in the absence of parents.
Santosh,
Yeah.
one second. Less than 12 years of age, the kids are not, or they can't give consent, and it has to be taken from the parents. And from 12 to 18, we can take consent of the patient and the parent. And above the age of 18, it should, if the patient is conscious, we should take the consent.
Yeah,
only from the
for an argument's sake, let's accept, but on a practical point, I would urge my colleagues that if possible, below the age parents and above the age of 18, below the age of 18 parents and above the age of 18, because this may not have been addressed in many courts, and it's better that we fall on the positive side rather than on the negative side.
The question of consent does not arise much.
Yeah, I'm just giving, because this is something which happens in surgical forum. That's the reason why.
Below the age of 18, only for the procedure which may not endanger the life.
Okay, fine.
That's the most important.
Yeah, okay,
After
fine.
the 18, in any procedure, he can give a consent.
Yeah,
In the present era, the person to give consent, we have to treat many patients from outside the state, these laborers patients. Only friends will be there, or their supervisor or owner of the firm will be there. I think they can give consent.
Anybody
good interest of the
who is responsible, as sir has said, anybody who is responsible to make the decision process, they are the people who are probably, I'm just looking at the legality.
But after the age of 18, the patient himself.
Yes. Yeah. But that brings to the question of a patient who is.
Regarding the age also, after 18 age, the patient may be disabled.
That we have addressed, sir. That we have addressed. Mentally deranged, not. Yeah. Mental, that we have already addressed. Mentally deranged.
Not only age.
Yeah, I agree. That is mentally deranged, inebriated.
Life-threatening സമയങ്ങളിൽ no need of consent.
I'm just coming to that.
Emergency.
Because there are occasions when surgeons are confronted with unknown patients who are brought with nobody. Somebody picks up from the road, an accident, unconscious, and this is possibly something which, as administrators, always raise to the level of the superintendent. And, how do you go about this?
If the patient is unconscious, the treating doctor can decide. If it's an emergency situation, the life has to be taken care of. So the doctor who is going to treat that patient can give consent and they can treat. And one more person also can be involved. If two doctors are involved, that is fine. And another thing is, if a procedure is to be done and if it's an emergency, there is no confusion regarding that. But if the patient is, again, another destitute patient, patient can be conscious, fully conscious. But if patient is conscious, then we can take consent from him. What I get is, occasionally I get requests or consultation for consent by the superintendent, and that is not necessary at all, because they can inform the authorities that such a patient is in the hospital and such procedures are required. Apart from that, the consent is not given by the authority. The patient is conscious, he will give a consent. If it's an emergency, and if the patient is unconscious, that will be dealt by two qualified.
Yeah, so the message should be the litigation and the process of litigation, your decision to take the patient to the theater without the consent stands to be testified by another surgeon if possible, another medical colleague if possible. That stands a long way in your litigation, preventing you from litigation that somebody else was also equally convinced that the patient had to have an emergency surgery to save the life.
And there will be witness also.
Yes, needless to say that every consent, and I think in the passing we mentioned that to what extent the revelation about possible complications and alternatives, benefits, etc. has to be done. I think this is, little dicey. Say, for example, do you always talk about bilateral recurrent laryngeal nerve palsy and the necessary tracheostomy before every thyroidectomy to that extent? Dr. Srijain?
A patient should be informed about these things. Otherwise, finally, if something goes wrong, then the patient start talking about you have not revealed this information. But at the same time, we are not asking the driver of a bus whether you are going to reach Malappuram or Kannur.
On the same note, I understand. On the same note, let me ask Dr. Hitesh, do you think that the cost involved in the treatment has to come in the consent form?
Definitely.
Yes. This is something which recently there was a case where in the apex court, it was verdicted against the surgeon for having not mentioned the cost, and that was one of the reasons why the surgeon was found, liable for punishment, because if they had been, the argument taken was, if they had been informed about this particular cost for this treatment, probably they may not have opted. If everything goes well, every patient is very happy and they are not grateful to you. The moment it starts going against the thought process of the patient, every surgeon is wrong. That's the basic idea. Dr. Hitesh.
That is why this is procedure specific consent must be. Every procedure separately explained to the patient with its benefits and risks and alternatives, and get the consent. And out the cost of the treatment also should be explained to the patient.
So what is the alternative? Let me ask a silly question. What's the alternative if a gynecologist decides that a cesarean section is to be done on an emergency where both the patient's and the child's life is at stake? What's the alternative?
In such cases, alternative may not be there.
May not be there.
Vaginal delivery and cesarean section, that should be.
Yeah. So this particular question I have brought in because most of the hospitals are moving to NABH, and NABH people who are not doctors, they always insist that there should be, alternatives, this thing. They don't understand. There are no alternatives, for certain surgical problems, fracture or hernia. What's the alternative? There is no alternative other than to operate. That's it. Last question on this consent part comes to Dr. Mr. Khadar. You mentioned that the refusal of consent need to be documented. Would you like to say a couple of words on that?
When the matter reaches it before the court or forum, civil, ഇവിടെ ആയാലും അവിടെ എത്തുമ്പോൾ ഞാൻ റെഫ്യൂസ് ചെയ്തിട്ടില്ല എന്നവർ പറയും.
Yeah, I would like to recall I would like to recall one of the apex court verdict against where Dr. T.T. Koshi versus somebody, I forgot the name of the opponent, T.T. Koshi versus in the Supreme Court, they have the defense taken by Dr. T.T. Koshi, was a legendary surgeon in practicing in Cochin a few decades ago. He took the stand that he did not do appendicectomy because the child's parents refused to give consent, and hence it was delayed, which cost the life of the patient. And the Supreme Court found that to that extent, if the child's life was at stake, the refusal of the consent should not have been taken in seriously. So he has failed to document that, and that probably would have cost his punishment. Am I right, sir?
You are right. You are right. But better footing, if you get a refusal recorded, it's good.
Yeah, I'm just saying that why the importance of that statement made by Advocate
I would
Khader.
just like to add one more point regarding this refusal of consent. We face sometimes by some group of people like Jehovah people. They will refuse for blood transfusion, a major surgery. In such things, it's always better to document that and get it signed by them.
Consent for blood transfusion should be separately taken.
That's true. That's true.
And one more thing, the remote complications which may come during your treatment may not be discussed with the patient. It is immune for the doctor.
What's your last question on this? What's your take on, recently there was a Lokayukta, not Loyakta, the Consumer Protection All India, there was a verdict that handwritten consent versus printed consent. The printed consents are not valid. What's your take on that?
Both are acceptable, but handwritten means Orissa High Court has judged that it must be legible, neat, in capital letters. Such directions are also there from High Courts. But printed consent is also acceptable here.
So one thing is that the signature is very important because signature has life. The patient himself can sign the document, but thumb impression is not good because it has no life. Even after death, the thumb impression can be kept. So signature of the candidate or the patient is a must.
So here, thumb impression is also acceptable if the patient is not in a position to put a signature. But the problem is that if it is denied, fingerprint expert, that is the difficulty.
I think we should conclude the consent part of this because we are running short of time. We move to the documentation part of it. We right now are moving from a physical format to electronic format. Where do we stand today? Either physical or electronic or a combination of both, Sri Kumar.
I think considering the various circumstances in different institutions, I think it should be both. Written or physical forms should be there, and if it can be stored in an electronic form, that's fine. But in documentation, what I feel is we should, to the postgraduates especially, we should stick to the basics. I have seen my professors like Babu sir writing the operation notes himself after the procedure. But now that trend is coming down. We delegate it to the junior most person or the postgraduate who assisted the procedure. But I think more than doing the procedure in such a good fashion, the best way to prevent litigation is whatever you have done should be documented by the surgeon, or if he is entrusting someone else to do it, he should read and make the necessary corrections in the operation notes. So always stick to the basics. That's what I have to say.
Yeah, the other point which I wanted to carry on with is whenever there is a police case, there is a case sheet seizing phenomenon that happens. Whenever there is an FIR that is filed or a criminal case being filed, I would like to draw the comments on this by Dr. Khader, Mr. Khader.
DOSP level police officers have got the authority to seize. They can seize the records. And the hospital records, including case sheet, is the custody or the property of the hospital, and you have to keep the documents up to 3 years. That is allowed. But if it is requested by police or patient, the copy has to be given within 72 hours or 3 days.
In police, any police person coming in?
Any police person can come and ask, request. If they will give you a receipt.
No, do they have the authority to seize? Or who is the authority to seize?
Police has got the authority to seize it.
So the original has to be given to them.
Original has to, if you give original, you have to get a receipt from them. Copy is enough. Original compared, that is enough.
I think it's very important at this stage as a practical thing. Before you do anything, please number every single page.
Yes.
Because these people can miss a sheet and then add a sheet and claim that whatever records that you have given to them is tampered or tampered.
And in addition to that, you can attest it.
Yes.
Stating that so much pages are given.
Yeah. So my, Dr. Hitesh, if you want to add something.
Once case is registered, belongs to the state, that on behalf of the state, the police is coming to seize the documents. And the police has every right to seize the documents. At the same time, if you didn't give the case sheets, they can take it through the CRPC, Criminal Procedure Code, 91 CRPC, I think.
The judge can order,
they can
issue a warrant
to bring the case sheet to the police station. So it is better to take
Hand over.
all the copies, better to attest each pages of the case sheet and hand over to the police.
So a formal request has to come in, if I may be, a formal request has to be coming in. You receive that formal request. In the formal request, take the photostat, numbered, attested, and give, and then get a receipt from the policeman that this particular case sheet.
At the same time, when the police has seized the records, the patient may give or file another complaint in a civil court where the case sheet is also.
I'm coming to that. Yes. Yes. Yeah, I'm coming to that. Simultaneous filing of petition on the same ground in 3 different judicial forums: criminal forum, police, civil forum, and even consumer. They can move to all 3 different. I'm coming to that in a while.
Yes.
So what we must be doing as a precaution. So it's better to have the receipt. Also, so many papers have been received. That should be given obtained from the police. And very often these are dealt by the administration without the knowledge of the concerned doctor, because the surgeon who is concerned may be totally unaware of this. It's given by the administration because it's an official purpose. What's your advice on this? The concerned surgeon should be kept in the loop, isn't it?
The documentation should be completed before going to this in medical record line. It should be completed.
Yes.
Page-wise, date-wise, timeliness, everything should be there. Then,
as a forensic surgeon, let me ask you, how do you find tampering of the case sheet by the surgeon or his team later on?
While looking at the case sheet, while documenting everything, it should be soap in documentation. It's subjective, objectiveness must be there, and assessment and plan must be there. Everything constitutes a complete documentation of a medical record. So, if the timeliness or date-wise or timeliness procedure-wise, sometimes everything there is a gap. If there is a gap in between, then
if I may cite an example, that 1235 in nurse's record and 1245 in the doctor's record, does it go against the doctor?
What was the procedure done by the doctor at that time, and whether I had seen that patient? Seeing the patient is very important for a doctor. Most of the clients comes when the patient
Yes, yeah. The problem is that the post-op issues are never handled by the concerned person. They relegate it to the junior person. That probably, at least in the nurse's record, at least they should find that so-and-so has been consulted and came and examined the patient. That will solve halfway through. So whenever you have this kind of things, completing the case sheet, at least in a medical legal forum, is an important duty of the concerned departments and concerned people.
The team must have a coordination in comparison with the
Your
printed
sister might
record.
have written that I have telephoned the doctor. But
Yes.
the doctor has argued the court that I have seen that patient or that. But at that time,
There is no record. There is no record. And other things that go against the doctors in many of the things is, as I mentioned, signature, name, registration number, date and time. These are important things which are in the case sheets which courts take into consideration. So whenever you see a patient, even if there is nothing, develop the habit of putting your signature, name, date and time. That would help a lot in the in most of the surgical units today. Surgical checklists, WHO safety checklist is being done. And isn't it a good practice that to file this in the case sheet, which would help the institution and the doctors a long way, that everything has been checked, like name, register number, etc., etc. Okay. The other thing that comes very often in the hot public is MOP. And those who are working in the theater would realize that MOP in every hospital gets as a pack of X numbers, radiographically identifiable. Nurses take the counts. Nurses finally takes the counts and the surgeon says, is it okay to close the abdomen? First checklist is checking if first count is done, second count is done. And finally the MOP gets missed or something gets happened. How do you go about this, Dr. Hitesh?
Actually, it is the duty of the doctor to ensure that all the MOPs were cleared from the body, from the patient. And actually the sisters or nurses are assisting the doctor. But it is under the supervision of the doctor, the entire procedure is being carried out.
You mean to say that doctors only have a vicarious liability or?
No, he has the liability. He has the direct liability the doctor has.
He's fully responsible.
Yes, he is fully responsible.
Fully
A
responsible.
registered medical practitioner or a doctor.
Yeah, and we are just talking only about the
He
surgeon.
has full responsibility over this.
Right. So how to ensure this? We'll come back to everybody.
I think, again, sticking to the basics before closing the abdomen, as sir rightly said, we will be asking them, but I think the surgeon and the nurse should combine verification of the MOPs and the instruments. And before the patient leaves the theater, that should be checked and signed by the surgeon after the procedure.
Yeah, and also most of the hospitals these days keep a checklist of the counts. Checklist of the counts, and that book has to be a very precious legal document that at least 3-4 people have checked it. The circulating nurse has signed it, etc., will go a long way in protecting ourselves. Multiple levels of entry. It's not something which will not happen. What if you are getting a foreign body from the abdomen? What is the surgeon supposed to do? I'm asking you.
If the body, it has to prove a civil case or tort.
No, I'm talking about, I'm operating and my preoperative diagnosis was a leftover MOP. The patient came to me with sepsis and I know that I have investigated and found that there is a MOP.
That is gross negligence.
No, let me not have the issue of the other person. I'm operating. It's a surgeon has operated somewhere else. I know the surgeon also. What am I supposed to do?
You have to record this. You have to document everything.
And tell?
And it's not need to intimate to the police or intimate to give intimation to anybody. But
Not even to the patient?
But you have to tell the patient that there was a move I have taken out and you have no sequelae, or if there is sequelae, what's the sequelae?
What if I keep it and not tell the patient? If the patient trusts me, the patient goes without any problem. I record it. Obviously, I retrieved one. Do I have to really trumpet it to the patient, keep it silent, and then do something? I'm just giving you a thought process. I am trying to help my colleagues. I'm not saying anything to the patient. Patient goes home, and that's it.
Later on, it will find.
Why? Patient has gone home. Do I have to really trumpet?
No,
Because
no.
the reason why I'm telling is I have had at least two occasions when the surgeon who has conducted the second surgery has summoned a press conference kind of a thing and disclosed that I have retrieved this from the abdomen and the bronchus of a patient, and that has created a lot of issues to the patient. So it should be played down. Why we document this? For our own safety, and secondly, these patients can give rise to problems like it can have a fistulations. Then the liability is on you. You don't have to really trumpet it. Then last question to you would be, I retrieve a mop. What do I do with this mop?
To whom?
I'm the second surgeon. I retrieved this mop from the abdomen. What do I do with this mop?
You must divulge the thing.
No, that's okay. That's okay. Is this a piece of evidence?
Yes, definitely. It's
So what do I do with this?
You keep that remote. You keep
Yeah,
it.
that's again an important point. This way I wanted to. I'll come back to you, sir. I'll come back to you because this is again an important point which I wanted. Any disagreement from your side?
Actually, sitting on the surgeon side, it is different, and sitting on the other side, it is different. So if we retrieve a mop, actually we have to keep it safe. It should be sealed, and it should be sealed. the seal which, and a note also is kept, and that should be sent to the investigating officer, or this becomes a property of the state. It is not the
Yeah, if the case is not there, if there is no case, there is no investigating.
Case is registered,
Yes.
or if there is
No,
a problem.
yeah, that's right. That's what I'm trying to tell. The second surgeon will be at liability if something happens. So this is a piece of Srimar.
Even if there is no case, what I feel is if you retrieve a mop, the patient goes home fine. As you said, if there is a reliable bystander, probably you can inform him.
Yeah, so
Have removed because the patient, if that knows, he might be upset. So
Yeah, I think it's just like breaking a bad news. We need to use our common sense to what extent, in what way, in what context that we need to talk to this. A patient who is uneducated, who is litigant, would get upset by the fact that the mop was left over and you have retrieved it. Most importantly, I wanted to tell you the fact that this is a piece of evidence in a court of law. So don't discard it, keep it at least for your safety. Will that be of?
One more thing I would like to add, because a lot of stories we have heard from our seniors that the professor has retrieved a mop and this was discarded without informing anyone in the theater. But nowadays, most of the time, what we do is a laparoscopy, and it is visual for everyone in the theater. So, in this situation, what are we going to do?
You answer.
Because people can see this, they can record it, they can. It's a visual evidence for everyone.
Sir,
I am not a party to this discussion. This is against Article 21. Life to health is life to life. Right to life. Right to health is right to life. So the doctor has the duty to disclose such things whenever it finds. This is called the res ipso loquitur in law. Res ipso loquitur means no further evidence is needed. ഏതെങ്കിലും കാലത്ത് കണ്ടുപിടിച്ചാൽ ഫർദർ എവിഡൻസ്
സാറേ നമ്മളിപ്പം പറഞ്ഞ് ഡിസ്കസ് ചെയ്ത് പറയണ്ടെന്നല്ല, ഏത് രീതിയിൽ എപ്പോഴും ചെറുതായിട്ട് പറയണമെന്ന് മാത്രമേ.
Don't think in this way at all.
Yeah.
You see, let me say the one more words. ഇപ്പോൾ ഒരു മാരേജ് ചെയ്യാൻ വേണ്ടി തീരുമാനിച്ച ഒരു പുരുഷനും ഒരു സ്ത്രീ, പുരുഷനെ ഡോക്ടർ പരിശോധിച്ചപ്പോൾ HIV പോസിറ്റീവ് ആണെന്ന് കണ്ടു. ഡോക്ടർ വല്ലാത്തൊരു പൊസിഷനിലാണ്. അതൊരു സ്വകാര്യമായിട്ട് അദ്ദേഹം സൂക്ഷിക്കേണ്ടതാണ്. റൈറ്റ് ടു പ്രൈവസി ഉണ്ട് ഈ പുരുഷന്. പക്ഷേ റൈറ്റ് ടു ഹെൽത്ത് അതിനേക്കാൾ ബെറ്ററാണ്, അതിനേക്കാൾ വലിയ ഇമ്പോർട്ടൻ്റ് ആയിട്ടുള്ള ഡ്യൂട്ടിയാണ്. ആ പെണ്ണിനോട് അത് പറയണോ വേണ്ടത്, യു ഹാവ് ടു ഡിസ്ക്ലോസ് ഇറ്റ്. ആ കുട്ടിയുടെ റൈറ്റ് ടു ഹെൽത്ത് ഈസ് മോർ ഇമ്പോർട്ടൻറ്റ് ദാൻ ദ റൈറ്റ് ടു പ്രൈവസി ഓഫ് ദി പേഴ്സൺ.
We will right to retrieve from there and go to the next topic. Otherwise, this will be an endless process, because we can have HIV patients in various ways. We will argue it out, and you can have so many things. So now the next thing is, I have another 15 minutes. Madam, am I right? 15 minutes? How many minutes more? 15 minutes? Okay, I'll just dwell upon one of the other things also. See, there are occasions when there is a untoward thing which has happened, unfortunate bad event leading on to death, which we are not able to explain, right?
Not negligence. No negligence.
Negligence, the surgeon, the operating surgeon doesn't feel that there was any negligent act.
Not liable. He's not liable.
No. My question is, there is a mob which is going to say that surgeon is at fault, there is some commotion. Can we ask for a postmortem? Can its operating surgeon, he himself can ask for a postmortem?
If the cause of death is unknown, you can request for a postmortem. And next question you have given me is that what is the procedure? No question of procedure, inform the police. The other thing will do.
Vijay?
Any unnatural that is a surgical or anesthetic death is a medical legal case, and this has to be informed to the police. And
Anesthetic death is defined as within 24 hours of, as per the anesthetist, any untoward things which is happening within 24 hours of anesthesia.
Perioperative, death that occurs in the perioperative periods.
Right.
It can be anesthetic. And if the patient challenges that the death was due to...
No, patient is not challenging. Patient is agitating.
Not the relatives to the patient.
Patient is agitating.
It is due to anesthesia, due to the...
Not anesthesia. Anesthesia comes in the background, and you have a 28-year-old man,
No, consent should be taken for...
Consent, everything is...
Separately for anesthesia also.
No, that's right. Everything, as far as you are concerned, everything is perfect. But unfortunately, due to unexplainable reasons, the patient is sinking. Let's imagine that patient has been taken up for, a laparoscopic procedure. An air embolism occurs, or a fat embolism occurs in fracture femur, and the patient says that it is all because of the negligence of the doctor.
If the doctor, treating doctor, couldn't explain the cause of death,
yes,
it should be informed.
No, they are not willing to accept. They are not willing to accept, and there is a confusion that.
Then definitely you.
Yes. So in case where there is a situation where cause of death is not, clear, or if it is debatable, it is possible that we ourselves are better positioned to ask for a postmortem. Yes. And in
one more thing, pathological autopsy also can be asked, and it is done by the pathologist, and the consent has to be obtained from the relative.
Do you think that the Indian culture and Kerala culture would?
May not be, but
yes.
In ideal situations, if we are not sure about the diagnosis, we can definitely ask for a pathological diagnosis of a particular area, maybe brain, maybe lung, maybe liver, like that.
Yeah.
And the consent for that particular portion autopsy can be requested from or obtained from the relatives.
Yeah, now we have suggested that autopsy is to be done. For social reasons, now the patients are not willing.
The only thing is that we as clinicians are not asking for postmortem. We are going to keep the body in the mortuary for completing the medical legal formalities.
Exactly.
We are not asking for postmortem, and in the...
No, now we have asked for. We have gone to the court, we have gone to the police and filed a petition stating that there is an agitating mob and the cause of death is unclear, and we request.
If the doctor asks for postmortem, that will be done.
You are not supposed to ask for postmortem examination.
Right.
You intimate the same to the police. They will decide. Then the with police.
So police can decide,
Police can decide.
police can decide whether postmortem is required or not.
That is the reason why I told inform the police. That is your duty.
Only thing you have to do is to inform the police.
And the situation now comes in, the police does not act. They will say that we have received the complaint, സാറേ അവർക്കിപ്പം പരാതിയൊന്നുമില്ല, ബോഡി വിട്ടുകൊടുത്തേക്കട്ടെ. ഇത് സാധാരണ കാണുന്ന കാര്യങ്ങളായതുകൊണ്ട് ഞാൻ പറഞ്ഞത്. ഇത് സാധാരണ കാണുന്ന കാര്യങ്ങൾ.
Let the police to release the body.
Exactly. They wouldn't like to sign. That's the reason why they put the poll in the court. So you sit tight, you ask them to release the body on their signature. Right. So that problem is also addressed.
Thing is, when you intimate to the police, we write, for completion of the medical legal formalities, the body is kept in mortuary. And another part also is usually written by someone, that is requesting for postmortem. So what the policemen usually do is that if the doctor has requested for postmortem, they will continue with that. What is your opinion?
If the doctor asks for postmortem examination, they will definitely do this according to CRPC 174. They will definitely go for postmortem examination. But in some instances, they can decide, after discussing the matter with the relatives, sometimes they may reach a consensus of opinion and they may release the body without postmortem examination. It is not at all necessary to do postmortem examination in all surgical deaths. If sometimes the surgeon can explain the cause of death to the police and police is convinced about the cause of death, and what the explanation you have given to the police has a logical basis and it is again accepted by the relatives, it may be released without postmortem examination.
Everything like that has been done. After going home, after the burial is done, after 3 days, the relatives now finds it difficult to accept and ask for a, postmortem.
Then again, while perusing the case round, whether it is everything is documented, sometimes the postmortem examination may not be needed.
Okay.
But if it is not documented, sometimes examination may be done.
Okay. Now, is there anything more to be added to this discussion?
You have to leave such questions to police. Don't keep it with you. You are informed police. Burial കഴിഞ്ഞ് 2 ദിവസം കഴിഞ്ഞാണെങ്കിൽ let them do or not do.
Okay. We are not party to that. We are not, party to the decision. Now, very often, this group of people, they will reach the police, they will write a letter to the chief minister, they will write a letter to the DMO, etc., etc. Is it possible for the same group of people, for the same complaint, to reach different authorities simultaneously for remedy?
Yes.
Yes, definitely.
And that is the reason why Sir has said.
Nowadays, these medical negligences complaints are given to Human
Rights Commission too.
Rights Commission, Children's Rights Commission.
And women.
I have had an experience of Minority Commission also. Notice, I don't know what is the connection between Minority Commission with this medical negligence. Complaint.
News value, sir. News value.
News value. That means doctors are fearing public and medias. You should not enter into a theater with a legal mind. You enter the theater with a medical mind.
Okay.
Keep the legal things outside the theater.
Last.
That's the only way.
Yeah. If you are acquitted in one forum, does that mean that you will be acquitted in the other forum?
If you are acquitted in criminal case, that will not affect the civil case. But two civil cases cannot be done. Consumer ഫോറത്തിലും സിവിൽ കോടതിയിലും ഒരേ സമയം കൊടുക്കാൻ പറ്റില്ല. ക്രിമിനൽ കേസ് ചിലപ്പോൾ അക്വിറ്റ് ചെയ്യാതിരിക്കാം. There you have to prove the gross negligence beyond doubt. The other place it is not necessary. That's only a question of compensation. So doctor has a duty to care breach, then there is a breach. As a result of the breach, there is a damages. That compensation question is dealt with the civil forums.
Or the
3 types of liabilities are there: tortious liability, contractual liability, criminal liability, penal liability. Tortious means civil wrong. That's all.
Thank you. There are lots of other legal aspects, but then our time does not permit us to go beyond this, Srikumar, you wanted to say something?
If such a mishap occurs, as you said, after 3 days, the bystanders suspect some foul play. In such a situation, I think the lawyers are better persons than us to give the advice. So IMA has got the PP scheme.
Yeah. No, I just wanted to bring, point of discussion. That's all.
Only thing is that before communicating to the patients or relatives again, we should be having a legal opinion with us.
Okay. So I think I would.
The perfect documentation saves the doctor. It will give you everything about the patient and what the procedure you have done on that patient and what are the things you explain to that consent form and everything. This consent, the Balam test, as I told, this Balam test is actually a real consent test.
Sir, we have operated a trauma patient, and there was a liver injury. We managed it conservatively. We were forced to operate this patient, and as most of my colleagues would agree, that we pack the abdomen. And there are 20 packs. We have documented it, and the patient died in the post-operative. Do you have to retrieve this pack, or just give it in writing that I have kept 20 packs?
No, the procedure patient died.
Keep the packs there.
Yes,
document it.
Yes,
Yeah. Okay. Fine.
One thing. There are so many other things are also there which we did not discuss here. See, today morning also a surgeon came to me. The question was the material used for the orthopedic ORIF, open reduction internal fixation, ഉപയോഗിച്ച കമ്പി പൊട്ടിപ്പോയ കേസാണ്. What does it mean? Material kept in the hospital is also important. That may affect you.
Yeah, sir, നമുക്ക് എല്ലാ ആസ്പെക്റ്റും നമുക്ക് ഡിസ്കസ് ചെയ്യാൻ പറ്റത്തില്ല, അതുകൊണ്ട് ഞാൻ അങ്ങ് നിർത്തുകയാണ്.
Like that move, if any legal question comes with regard to that move, that can be examined during the postmortem exam.
Okay, fine.
Number of moves.
I understand. Just for the completion's sake. So I like to close here because there is a lot of questions that is possible, and social media doing the വിസ്തരിക്കുന്നത് മുഴുവൻ സോഷ്യൽ മീഡിയ ചെയ്യുന്ന ഉൾപ്പെടെ ഒരുപാട് കാര്യങ്ങൾ നമുക്ക് ഡിസ്കസ് ചെയ്യാം. അതൊന്നും ഈ 1 മണിക്കൂർ കൊണ്ട് നമുക്ക് ഡിസ്കസ് ചെയ്തെടുക്കാൻ പറ്റത്തില്ല.
ഞാൻ പറഞ്ഞു വയ്ക്കാം. ഇപ്പൊ അടുത്ത് വന്നൊരു നെഗ്ലിജൻസ്, ഒരു മോപ്പിന്റെ അതുമായി ബന്ധപ്പെട്ട് ഫോറിൻ ബോഡി റിക്കവർ ചെയ്ത കേസിൽ നമ്മളുടെ ഭാഗത്ത് നിങ്ങൾ സർജന്റെ ഭാഗത്തു നിന്ന് തന്നെ വന്നൊരു ഒപ്പീനിയനെ കുറിച്ച് ഞാൻ പറയും. അതായത് റെസ്റ്റിപ്സലോക്കിറ്റർ, ഖാദർ സാർ ടോൾഡ് us, it is a civil wrong, not a criminal wrong. It is not criminally wrong. അതൊരു എവിഡൻസ് മാത്രമാണ്. അത് വെച്ചിട്ട് that cannot be taken as a criminal wrong. It definitely reciprocity is a civil wrong. But one of our surgeon opined in the forum that it is a negligence, a criminal negligence. And that was taken into consideration by the police. And the doctor is now sued, I think, according to 338 IPC. But actually, ഞാൻ ഒരു ചെറിയൊരു കാര്യം പറയും. ഇപ്പോൾ തീ ഉണ്ടായ പുക വന്നാൽ മതി, പുക കണ്ടാൽ നമുക്ക് സിവിൽ റോങ് എന്ന് പറയും. പക്ഷെ പുക ഉണ്ടാകാനുള്ള കാരണങ്ങൾ എന്തൊക്കെയാണെന്ന് ഓരോന്നും കണ്ടെത്തിയാൽ അതൊരു ക്രിമിനൽ റോങ്ങിലേക്ക് എത്താൻ പറ്റും. Always this reciprocity is applied only in cases of a civil cases. It is evidence. The other thing is also an evidence, but it cannot be considered as a gross negligence on the part of doctor.
Okay. I would like to close this because the whole thing, the gamut of legality in medicine or in surgery is phenomenal. I would like to have some questions from the practicing surgeons, if anything. Be very brief, otherwise it's an endless process. Dr. Shabir Ali.
Thank you, sir. It was an enlightening panel discussion. Basically, you said about mentioning the complications, surgical complications in the consent. I think in UK, they mention everything above 0.1%, which is described in the literature.
Sir, I have worked in UK. The way, suppose നമ്മുടെ ഇവിടുത്തെ ഒരുത്തൻ്റെ അടുക്കൽ നമ്മൾ ഒരു ഹേർണിയ ചെയ്യാൻ വേണ്ടി വരുന്നു, അല്ലെങ്കിൽ ഒരു ഗ്യാസ്ട്രക്ടമി ചെയ്യാൻ വേണ്ടി വരുന്നു, and he has got 15% ejection fraction, renal failure, half of liver is gone, and he is jaundiced or he is ascitic. And the question that comes to you would be, doctor, and the chances and the risk എങ്ങനെ ഉണ്ടെന്ന് ചോദിച്ചാൽ നമ്മൾ ചിലപ്പം പറയും ഒരു ആർഗ്യുമെന്റ് സേക്കിന് വേണ്ടി പറയും he has got say 55% of death and 45% of നമ്മളെ കോർണർ ചെയ്താൽ എന്ന് പറഞ്ഞാൽ വേണ്ട. നിങ്ങൾ സായിപ്പിൻ്റെ അടുക്കലായത് പറയുന്നെന്നുണ്ടെങ്കിൽ അവൻ പറയും 15% chances of survival. Oh, doctor, you go ahead. I can leave 15%. Go ahead, do the operation. It's the perception of the mind of the receiver that is quantified and that is giving the consent. So, Indian situation is slightly different.
There is no cutoff.
There can't be a cutoff, and it's the patient's perception and acceptance.
Like a cholecystectomy, you got a cardiac event after that. It was not mentioned. Nobody expects that.
അതാണ് ഞാൻ ചോദിച്ചത്, നേരത്തെ ചോദിച്ചത് 2 words ആണ്. Thank you.
One of the case, the apex court had clarified that remote risks may not be explained to the patient.
Okay.
Shall I add a comment to that? Because with due respect to K.N. Khadar sir and all the legal experts, at times what has been called labeled usually as gossypioma, a mob kept inside the abdomen. Now we have a conscience and we have a legal protection requirement on opposite sides. Sometimes if it doesn't affect the outcome or it may not be causing any problem to the patient, 2 occasions where it happens once for me in KIMS Hospital, Trivandrum. I was coordinator. I don't want to mention my coordinator's name. Senior person was consulted. I had to open a gossypioma suspected case, a documented case. So sir was giving me a very nice advice because the gynecologist who did the cesarean was having his own son's father-in-law as also not the coordinator of the office, and he was giving.
You are giving more clues for the identity.
Yeah. No, but then the hint he gave to it, the tactics worked very well, because at times we don't want to create. So this can happen. Unfortunately, no surgeon, no gynecologist deliberately, intentionally keeps anything there happen. But if it is under our control, without any consequence to the patient, there are certain tactics, so which I applied, because sir was telling you put in a lot of mobs there, and in a hurry, when you want to remove it, you can just incorporate the other things. So that
ഇതൊക്കെ പണ്ട് നടന്നുകൊണ്ടിരുന്ന കാലമാണ്. അതുകൊണ്ടാണ് ഇപ്പം നമുക്ക് വിഷ്വലൈസ് ചെയ്യാന്നൊക്കെ പറഞ്ഞത്.
I know that, but the message which I wanted to tell is the second case was again in Trivandrum Medicola itself. One of the orthopedician was having a pinning done, and the head, the ciliate part was gone into the peritoneal cavity with the piercing the acetabulum. So what we did was, general surgeon was called, duty surgeon was called, because it was an RTA. So what we did was, there was a blunt injury abdomen indication. So we did it and we explored and we have marked certain things. This was removed but was not documented. Now, I'm not telling it as a legal advice to the forum to follow, but at
Thank you, sir.
my message is, at times when we want to help, if you feel nothing will be wrong for the patient, and this has to be considered in contrast to the legal consequences.
Thank you, sir. Thank you.
Permission of Dr. Santosh John. ഒരു വാക്കെങ്കിൽ പറയാനുണ്ട്. ഈ മോപ്പ് അവിടെ കിടന്നത് കൊണ്ട് അദ്ദേഹത്തിന് ഒരു കുഴപ്പവും വരുന്നില്ലെങ്കിൽ ഒന്നുമില്ല. പക്ഷേ ഏതെങ്കിലും ഒരു കാലത്ത് അത് കണ്ടുപിടിച്ച് വന്നാലുള്ള ഇഷ്യൂസാണ് ഞാൻ പറഞ്ഞത്.
അതെ, നമ്മൾ അതിനെപ്പറ്റിയാണ്
ഒരുപാട് കേസസ് ഇപ്പൊ ഈ കോളിസിസ്റ്റക്ടമി, ലാബ് കോളിസിസ്റ്റക്ടമിയിൽ സ്പില്ലോവർ ആയിട്ടുള്ള സ്റ്റോൺസ് ഉണ്ടായിരുന്നു. ആ സ്റ്റോൺസ് ഒരുപാട് കാലം അവിടെ കിടന്നു. അതിനുശേഷം കാൽസിഫിക്കേഷനായി, വയറുവേദനയായി തിരിച്ചു വരുമ്പോൾ ഒരു ഡോക്ടർ തന്നെ ഒരു എക്സ്പേർട്ട് വിറ്റ്നസ് ആയിട്ട് വന്നിട്ട് സർജന് എതിരായിട്ട് മൊഴി പറയണം. ഡോക്ടർ പറയണം, ആ ഡോക്ടർ പറയുന്ന നമ്പർ ഓഫ് സ്റ്റോൺസിന്റെ എണ്ണം വർദ്ധിപ്പിച്ചു പറയണം, അതുപോലെ സൈസ് വർദ്ധിപ്പിച്ചു പറയണം. അതിന് മെഡിക്കൽ കൗൺസിലിൽ കംപ്ലൈന്റ് കൊടുക്കേണ്ടതാണ്. നിങ്ങൾ അസോസിയേഷൻ ഒന്നും കംപ്ലൈന്റ് കൊടുത്തില്ല, പാർട്ടീസ് ഞാൻ ഡിസ്ക്ലോസ് ചെയ്യുന്നില്ല.
ആക്ച്വലി എനിക്ക് ഇതുപോലെ തന്നെ കുറെ ചോദ്യങ്ങൾ ഉണ്ടായിരുന്നു. ഹൂ ഈസ് ദിസ് എക്സ്പേർട്ട്, വാട്ട്സ് ദ വാലിഡിറ്റി ഓഫ് ദിസ് എക്സ്പേർട്സ് എക്സെട്രാ. പക്ഷേ ടൈം ഡസന്റ് പെർമിറ്റ് ഇറ്റ്.
എക്സ്പേർട്ട് എവിഡൻസ് ഈസ് നെസസറി.
അതെ ഞാൻ
കംപ്ലൈനന്റ് ഹാസ് ടു പ്രൂവ് ഹിസ് കേസ്.
അതെ
നമ്മളല്ല.
Okay, thank you very much, sir.
Can I have one more question?
Sir, thank you.
Can I have one more question? Yeah. When you explain the complications of a surgery, what all complications? Any percentage cutoff is there?
Sir, അത് നമ്മൾ നേരത്തെ
below which percentage need not be explained, anything like that?
അത് ഈ പെർസെൻറ്റേജ് എന്നൊക്കെ പറയുന്നത് ഒരു ആർബിട്രറി സ്റ്റേറ്റ്മെന്റ് അല്ലേ. നമ്മളിപ്പോൾ ഒരു ആ പെർസെൻറ്റേജ് എന്ന് പറഞ്ഞൊരു ബുക്കിൽ എടുത്തു കഴിഞ്ഞാൽ 4 to 20% എന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ വേറെ ഏതാണ് എവിടെ എന്ന് പറയുന്നത്. ഇതൊക്കെ ഒരു കോമൺ സെൻസ് ഉപയോഗിച്ച് പറയുക, ഒരുവിധം റീസണബിൾ ആയിട്ട് പറയുക.
You have to document all those things. Write down.
അതിൽ കൂടുതൽ നമുക്കൊന്നും ചെയ്യാൻ പറ്റത്തില്ല.
So when you give general anesthesia, there's a chance that malignant hypothermia and anesthesia related death can occur in 1 in 25,000. That is documented. That has come down to 1 in 15,000 now. Right. So is it necessary to tell even that figure to a patient?
ആ കേസിൽ വ്യക്തമായിട്ട് പറഞ്ഞിട്ടുണ്ട്, ഈ സമീരയിലെ കേസിൽ വ്യക്തമായിട്ട് പറഞ്ഞിട്ടുണ്ട് റിയൽ കൺസെന്റും ഇൻഫോംഡ് ആണ്. അതിന് പ്രത്യേകം പറയും, ഈ റിമോട്ട് പോസിബിലിറ്റി ഉള്ള സാധനങ്ങളൊന്നും പറയേണ്ട കാര്യമില്ല.
വളരെ സെൻസിറ്റീവ് ആയിട്ടുള്ള കാര്യങ്ങൾ ഡോക്ടർ ഡിസ്ക്ലോസ് ചെയ്തില്ലെങ്കിൽ നെഗ്ലിജൻസ് ആവില്ല. അവിടെ പേഷ്യന്റ് പേടിക്കും. അങ്ങനെ
ഞാൻ സന്തോഷ് സാർ പറഞ്ഞ പോലെ US-ലെയോ അല്ലെങ്കിൽ UK-ലെയോ ഉള്ള ഒരു പേഷ്യൻസ് അല്ല നമ്മളുടെ പേഷ്യൻസ്. നമ്മളെ പേഷ്യൻസിന്റെ ഹൗ ഫാർ ഇറ്റ് ക്യാൻ ബി ഡൈവേർജ് ടു അവർ പേഷ്യൻസ്, that you must acquire from your practice and you must acquire from your common sense.
Next thing is
ഇവിടെ ലാസ്റ്റ് 30 ഇയേഴ്സിനിടയിൽ മലപ്പുറം ജില്ലയിൽ ഞാൻ നടത്തിയ കേസിൽ ഒരു 3 to 4% കൺവിക്ട് ചെയ്തിട്ടുള്ളൂ. ബാക്കിയെല്ലാം ഡോക്ടേഴ്സ് രക്ഷപ്പെടുകയാണ് ചെയ്തത്.
Thank you for that positive statement, sir. Last question from Sajid Edwin, and we'll wind up because it's an endless process. Sajid.
Is it necessary to take a high risk consent? Because we are quite often asked to we have taken a consent, but again they say you have to take a separate in writing a high risk consent.
Often this high risk consent is requested by the anesthesiologist for the risk involved in anesthesia.
That they are taking.
Let them take.
Not a surgeon.
Why should I take a informed consent for a hernia? My hernia is fine, but he may have only 25% ejection fraction or 50% renal function, and the anesthetist risk is high. You don't have. But then you always help the anesthetist by having a
risk medically calculate ചെയ്യുന്ന കാര്യങ്ങളാണ്. നമ്മൾ before doing the procedure you must explain every possible risk to the patient.
So we can't differentiate that. So we will say that you stand a high risk compared to me getting operated or you getting operated. Sir, you are a visitor, so I can't say no to you.
We get convict patients, sir. Convict patients from the prison. If they come for it, if we do an emergency, the concern should be before we get the concern from the jail superintendent, it takes time. So can we go on?
Emergency.
The surgeon can decide or the medical.
Emergency is emergency. Anybody can.
The patient is conscious. You get the consent only from the patient and not from the jail superintendent.
The convict, they don't.
No, sir. It's the convict or foreigners coming under, passport or.
Right to medical care is enriched in Article 21. It is a constitutional right of the patient, right to medical treatment. So you have to get the consent from the patient himself. If he is above 18 years old, no need to carry consent from the superintendent.
But nowadays in Kerala, the problem is public interference. Media interference.
Correct. So I would like to once again thank both Dr. Ms. K.N. Khader and Dr. Hitesh coming particularly from outside, and my colleagues Dr. Sri Jain and Sri Kumar, and hope you have enjoyed this. Thank you very much.
Thank you. We have a few certificates to hand out. May I request Dr. Santosh to kindly hand out these certificates. First to Dr. Sri Kumar, please. Thank you, sir. Dr. Sri Jain. Dr. Hitesh Shankar. And Advocate K.N. Khader, please. May I also request Advocate K.N. Khader to hand over a memento to our esteemed moderator, Dr. Santosh Abraham, please. Thank you very much to the moderator and the panelists. We have a hands-on session today for venous Doppler and the ultrasound abdomen for the residents during the lunch break at 1:30. The sessions will be at 1:30, I beg your pardon, and at the skills lab on the first floor. All the residents are advised to check if they are among the selected candidates for the session and attend it on time. The first ultrasound USG session and venous Doppler will be at 1:30 p.m. and the second session will be at 2:15. And for the information of the delegates, the lunch will be at 1:15 if we finish on time. Thank you. May I invite the next set of chairpersons onto the dais, please. Dr. Bipin will be chairing the session to be presented by Dr. Mohammed Ismail. Also on the dais, may I invite Chairperson Dr. Dayanand Babu, who will be chairing the session for Dr. Ajay Kumar, and Dr. Madhu Murali, who will be chairing the session for Dr. Dilip Damodran. All three chairpersons on the dais, please. And the first video presentation will be made by Dr. Mohammed Ismail, Senior Consultant, Maulana Hospital, Peridhanmalla.
Respected Chairman, senior teachers, my dear colleagues, ladies and gentlemen. After a very interesting session, we are going to have another video session. My topic is diagnostic laparoscopy. Warm greetings from Peridhanmalla to all. Diagnostic laparoscopy is a minimal access surgical procedure that allows the visual examination and documentation of intra-abdominal organs in order to detect pathology. As we all know that the advancement in the imaging, the role of diagnostic laparoscopy is coming down. Even though we know that the imaging is not 100% proof, otherwise in future we may not know. If you put the body in a machine, you can see through the abdominal wall all the intestinal organs. With the advancement of the technology, this may come. And if you look at the history, the first diagnostic laparoscopy was done by Kelling in a dog in 1901, and first in the human by a Swedish internist, Jacobs, for the ascites. The indications, we all know that the non-traumatic, non-gynec acute abdomen, any of the acute abdomen, sometimes even with all the diagnostic tools, there may be the diagnosis may be in a question like appendicitis, diverticulitis, DU perforation. But most of these cases, there may be the diagnostic laparoscopy may be converted to a therapeutic laparoscopy. In fact, the diagnostic laparoscopy is the first part of all the operative laparoscopy. So we must know how we have to do. We should know do the diagnostic laparoscopy first, and how we have to do it correctly. Like the gynec abdominal emergencies also, there may be a role of the diagnostic laparoscopy initially. Like the pelvic inflammatory disease is one condition where the patient is complaining of a lower abdominal pain without much evidence of any other clear pathology. For that, we can go for a look into the abdomen and see what's wrong with it. The ectopic pregnancy is nowadays, this is almost 2 decades back. Even the gynecologists were used to tell that you should not take an unstable patient for the laparoscopic surgery. But nowadays the things have changed, and the anesthetists also are very confident to do a laparoscopy for a fairly stable patient. The trauma is another area where the diagnostic laparoscopy is very useful, especially in a private setup, even though we are telling that the hemoperitoneum, the ultrasound shows that there is a hemoperitoneum. Most of the cases we may consider for a conservative treatment, but that can be happen only in an institutions where in many times when we work in a private setup, it is a difficult situation if the patient, after 1 or 2 hours, if he bleed and then the problem comes, then it is a problem. So when there is an equivocal situation, always it is better to put the scope and see whether there is an active bleeding, or you can give a wash, or we can put a train, and if the train is there, it is you will be in a safer side. Because the subsequent bleeding can be noted early. And in oncology, definitely there is a staging, and sometimes most of the oncologic procedures, it is better to put the scope first and see, because the resectability and non-resectability may not be completely, we may not know preoperatively with the imaging techniques and the other biochemical or the markers. The hemorrhagic pancreatitis, I told, because this is one condition where the you can confirm the diagnosis. Not only that, if you give a good wash, definitely that will help you to improve the patients postoperatively. So the anesthesia, it can be done under local anesthesia. If the patient is just for a diagnostic laparoscopy, you can do under local anesthesia, or a spinal, or if you are planning for a therapeutic laparoscopy further, then the patient can be, patient may have to be given the spinal or general anesthesia. This is one condition where initially the surgeon is using the camera and the another port, the instrument first, to see the intra-abdominal organs by himself. And once he decide on the therapeutic laparoscopy, then only the camera has to be given to the cameraman, and he has to put additional ports. The patient has to be examined maybe in the first tendon position, and the position has to be changed, or the patient, usually we start the diagnostic laparoscopy, the surgeon stands in the left side of the patient, and supraumbilical or infraumbilical incisions we are using, and most probably we may use a 5 mm port with 30 degree, and then we can change according to the further proceedings. Usually the diagnostic laparoscopy, as we know that whenever we put the first port of any laparoscopy surgery, it is blind. So you have to look into the track of the first your trocar, and then you start from the right iliac fossa clockwise, and you see the appendicecum, and then go up and to the right lobe of the liver, hepatic area, subdiaphragmatic area, and you cross the falciform ligament to the other, the left side, and take a complete rotation, and then finally come to the pelvis, where you will have a steep Trendelenburg position, and look into the pelvis, the anti-abdominal wall, and we know that in the pelvis there are 3 false ligaments, that is the medial, median, and lateral ligaments, and the 3 ligaments, that is the ilioinguinal ligament, Cooper's ligament, and lacunar ligament, and we have got 2 spaces. And I always suggest my younger colleagues to understand this anatomy. I mean, if you look into the lower abdomen, whenever you are doing a diagnostic laparoscopy or a laparoscopy for any other disease, you can spend some time in the lower abdomen and just imagine that area without the peritoneum, where we know that the hernia is one condition where we are going laparoscopically. Most of the surgeons are taking laparoscopically, but the anatomy is different, as in the TEP procedure that is only one surgery. We are not coming across in our open surgery. So to understand the anatomy of the anti-abdominal wall, always you take some time. As I told, you can recognize these 3 false ligaments, the ligaments, and the 3 areas of the triangle of the pain, the circle of Mortis. All these things you can understand. This is the video of the abdominal trauma. As I told earlier, this is we can look into the whole abdomen, and even sometimes the bleeding from the liver and the spleen can be managed electric, with the cauterization, or even you can put sutures. So this is a area where there is a bleeding, and this after a good wash you can use your cautery to stop the bleeding. If there are grade 2 or 3 injury, even you can put the sutures with the catgut or the so the stop the bleeding, and without opening the abdomen, you can manage many of the abdominal traumas through laparoscope. And this is a splenic trauma. That is another advantage of the laparoscopy in the splenic trauma, because whenever we are doing open the abdomen for a splenic trauma, usually we have to put your hand and palpate the spleen, and usually most of the time it will end up in a splenectomy. But in laparoscopy you are getting a good vision, and many of the times you can save the spleen by splenography or even the partial splenectomy. So the diagnostic laparoscopy and the therapeutic laparoscopy is very good for these type of the trauma cases, provided the patient's conditions should be stable. And in staging, even though with the advent of a lot of the imaging techniques, sometimes we may get a false information. This patient was having a CA pancreas. Recently we have done the reported as a metastatic nodules in the peritoneum. But there was only a few additions, and then we can proceed with the Whipples for this patient. And sometimes the opposite also can happen, severe infiltration to the adjacent vessels or the vascular invasions we can detect with the diagnostic laparoscopy, and we can abandon the procedure. You can see the difference between the tubercular nodules and the malignant nodules. Malignant nodules will be very shiny, and the tubercular nodules will be, it is a chronic inflammation, so it will be Duffy nodules. But definitely you can take the biopsies, and the other liver, you can differentiate between the hemangioma and the liver malignancy. And the laparoscopic ultrasound is another very useful modality of the treatment when we are using a diagnostic laparoscope for the resectability of a tumor. There may be a multiple liver abscess. This patient was aspirated 2 or 3 times by the interventional radiologist, and again they missed the adjacent abscesses. We can see that there was a large abscess in the subdiaphragmatic area, and there was another one in the lower part also. Sorry, that is not. And the endometriosis is another condition where the diagnostic laparoscopy is very useful, and we can complete therapeutically also. Even though there may be, again, you can aspirate this fluid, or but sometimes the definite answer we may get it with a peritoneal biopsy by doing a diagnostic laparoscopy, and this will give a definite diagnosis whether it is a chronic inflammatory conditions like tuberculosis or it is a secondaries from the malignancy. The Meckel's diverticulum is another condition. Always you have to look for. This patient was operated laparoscopically 3 weeks back, and again complaints of, many times we may get this scenario, complaints of pain, and a diagnostic laparoscopy after all these imaging modalities, if the pain is not subsiding, you can see sorry, 1 more minute, please, sir. And there was a large Meckel's diverticulum. This patient was missing by the first surgeon, which was the cause of the pain. and this was resected complete intraperitoneally. We are putting this is the clamps, intraperitoneal clamps we put, and resection and intraperitoneal anastomosis was done for a boy. So the challenging situations for the diagnostic laparoscopy, we may have to take care of if there is a previous abdominal surgery. So to conclude, it is a safe, effective, and cost-efficient and added value in determining the resectability over existing state-of-the-art diagnostic tools, and approximately 15 to 20%. May change the management. Laparoscopic ultrasound is accurate, but it is not available everywhere. And the future directions of diagnostic laparoscopy and LUS will involve the palliative and therapeutic interventions. Thank you, sir. Thank you for the question.
Thank you, sir. Well presented. My question is regarding the first report. Entry report in all your diagnostic lab cases, you will go through umbilicus, or if it's a peritoneal TB, delay for a peritoneal TB or a distal small bowel obstruction due to a band or adhesion, which would be your access?
I mean, in challenging situations like if there is a previous scar and you expect a lot of adhesions, it is better to go for, we have got the, you can put for the right hypochondrium or the left hypochondrium, you can change the positions. It depends on the situation. But generally, if there is no other problem, it is better go for the subumbilical or supraumbilical, so that you can put the additional ports, depends on the condition, therapeutic.
Any questions from the audience?
Thank you.
May I request Dr. Dayanand Babu to kindly hand over a certificate to our esteemed speaker. Dr. Dayanand Babu to hand over a certificate to Dr. Muhammad Ismail, please. Thank you, sir. Our next speaker will be Dr. Ajay Kumar, Senior Consultant, Saraswati Hospital, Parashala.
Ajay Kumar is specialist in diabetic food, and he is going to talk on preventive pediatric surgeries, surgical offloading.
Respected chairpersons, it is indeed a happy moment. I am standing in this podium after 4 years of my Rakhavachari oration in the same podium. Thank you, Captain and team, for the excellent conference. Without wasting time, I will go to the topic proper. Dear friends, this is an attempt to sensitize our general surgeon friends and junior folks to venture into surgical offloading procedures which are very effective and not very complicated, which you can incorporate in your practice. I bring greetings from my alma mater, Government Medical College, Trivandrum, and Saraswati Hospital, a bariatric, podiatric, and laparoscopic surgery center. Dear friends, I will start from the basic procedure which your paramedics usually does. It is callus cutting. Nothing but these calluses of these types are the opportunities given to you to save the patient from ulceration. Once you see this, unless you cut the callus regularly, it will end up in a neuropathic plantar ulcer. As you can see in the third picture, it has become an ulcer. Dear friends, it is done usually by a trained paramedics, and a very simple procedure, 20 or 21 blade parallel strokes. You keep on doing this until you get a flat surface compared to the skin next to it. No need of any dressing unless there is an ulcer. And another one which I want to highlight is a very simple procedure, needle tenotomy. Tenotomy, flexor tenotomy is a well-documented procedure for closed toes to prevent ulceration at the tip. Hammer toes, closed toes, and pressure ulcer on the tip of toes. You know the two toe deformities. One is a hammer toe, the other one is a flexor toe. The picture itself implies what is hammer, what is claw. If there is flexed DIP, it becomes a claw toe. For that, you can have open tenotomy and needle tenotomy. I will show a video clipping of needle tenotomy. See, you extend, keep the toe extended using a blood set needle from the side. You go and stroke, repeated strokes. You will feel the gritty sensation of the flexor tendon being cut. And one small point, if it is a little toe, the flexor tendon goes tangentially to the center. You have to enter the needle from one side, medial side. So, see, it has become straight. And you know, a group of ulcerations in the forefoot are due to overaction of the calf muscles. A very tense calf muscles, tendon Achilles is very pulling very much, and the foot becomes functionally equinus, where you have a variety of procedures to reduce the pull of the calf muscles, one of which is classical tendon Achilles lengthening, which we all know. I'll just show for demonstration purpose. This is a open TA lengthening. You can either put an incision like this, or you can put a lacy S incision where the incision line will not correspond to the line of the tendon. And as far as possible, please do it under tourniquet control. You will get a bloodless field. I'll fast forward. It's not a great procedure, but very simple. You do an Z-plasty where you lengthen the see, you make a cut like this. And you try to extend. See, you get this much lengthening you got. Okay, did you follow? Okay, you can suture it with a 10 or number 1 proline and close the wound and keep immobilization for 1 to 2 weeks, then start mobilizing, otherwise the surrounding fibrosis will impair. Okay, the next procedure I want to show you is a very simple one, simpler than the other one, that is a closed TA lengthening. See, this is, you make draw a line, then make alternate points on opposite side like this, and using the tip of your number 11 blade, make partial cuts over each points. And when you complete all the cuts, make a dorsiflexion, forceful dorsiflexion. There is partial rupture of the tendon and you get adequate lengthening. See, that is what we do. That finishes the procedure. In this case, you need not immobilize the ankle. Patient will be given an elastocrep bandage and he is asked to walk. And this is another procedure which is giving better results. It is called GSR or gastrocnemius soleus recession. What you do is, you have a functional equinus deformity and a tight tendon Achilles, and there is a possibility of future plantar heel ulcer if you have an open lengthening. The lengthening may be more and the gait will be on the heel only. In such cases, you select gastrocnemius soleus recession. I'll show you. The gastrocnemius soleus complex has got 3 zones, as you see, 1, 2, and 3. The 1 is completely muscle belly, 2 is partial aponeurosis and muscle belly, 3 is pure tendo-Achilles. Okay, we are making a small incision over the zone 2, and till you see the aponeurosis, you have a blunt dissection and see the aponeurosis clearly and make a transverse cut in the entire circumference of the muscle, and underneath you see the muscle belly. This is what the aponeurosis I am mentioning. See that white glistening aponeurosis is cut transversely. See? Okay, you can see when you dorsiflex, you can see the lengthening you have achieved. Okay, and nothing else, just close the skin. And Keller's arthroplasty is the one which you have to draw your attention for 1 minute. This type of ulcers at the PAP joint is very common. What we do is we resect the proximal portion of the proximal phalanx. Okay, and through a dorsal incision. My time is getting over. I will fast forward. See, find out the extensor hallucis longus, retract it, cut the extensor hallucis brevis and dissect the bone very close to it, and with a drill remove one piece of proximal P1, and that finishes the surgery. Release the tourniquet, apply hemostasis. It is called gap arthroplasty. And when you close the skin, the surgery is over. The thing you achieve is when you raise the heel. Okay. And metatarsal head excisions. I am not showing the details. You can have one metatarsal head excision, multiple excisions, or pan metatarsal excisions. Only thing, the same principle, through the dorsal incision, find out the metatarsal head, excise it, and close the skin. This is peroneus longus and peroneus brevis tendon transfer. It is nothing but, the peroneal overdrive. The lateral side muscle, peroneal muscles overact. The peroneal muscles are attached to the medial side of the medial cuneiform and part of first metatarsal bone. The foot is in an eversion and you get ulcer on the first metatarsal. So what you do is, you dissect the peroneal muscle tendons. The tendon lower down is the longest muscle, and the above is the brevis. You cut the longest tendon and attach to the brevis muscle. So the peroneal overdrive is reduced. The strength is reduced, and you compensate the over pull of the peroneus longus, and the eversion is reduced and the ulcer heals. It's a very simple operation. So my dear friends, this was an attempt to sensitize our general surgeons and younger colleagues about surgical offloading procedures, which is very effective, and it gives a permanent way of healing. You put a footwear, patient may not be compliant, the ulcer recurs. Knowing biomechanics helps you to decide on the type of procedure needed by the particular condition. Thorough knowledge of anatomy and pathophysiology are essential prerequisites. All general surgeon colleagues who have keen interest in podiatry can venture these procedures. This was just an overview only. A lot of procedures are there. Thank you very much for the patient hearing.
Thank you, Jay Kumar, for the very nice presentation. I think all these procedures are being done by Ajay Kumar on a routine basis. And any queries you can, very simple procedures. Any doubts, queries?
A simple, very nice procedure, but I have some simple doubt. I know it's a silly doubt or not. Do these procedures, what is the end point? Is it ulcer healing or prevention of future ulcers?
Yeah, it can be done for two things. Great zero ulcers. You know the deformity, patient is going to ulcerate, you can do. That is preventive. Then if you have an ulcer, you have tried conservative management, footwear, no healing, then you do this, continue the conservative, the ulcer will heal.
So regarding the TA lengthening and also the gastrostomy soleus recession, in such procedures, is it only clinical diagnosis or any investigation to support your diagnosis?
Yeah, there are a lot of clinical tests. For example, to find out perineal overdrive, patient is kept supine and ask them to dorsiflex. You can see the inversion. Just like that, clinical tests are a lot of tests are there.
I'm asking any further investigation. Is any
Not-
supportive investigation to whether this TA lengthening will definitely give a result to this patient?
Well, the biomechanical deformity you can demonstrate preoperatively. You can see the functional highlights.
So
For
it's
example,
purely clinical?
Yeah, purely clinical.
Sir, you do tender Achilles lengthening for all forefoot amputations to prevent further ulcerations or only in equinus deformity?
A lot of indications are there. One of them is forefoot amputations where the TA overacts and there is no extensor muscles. We have all cut. So in that case, the foot goes into equinus. In that case, it is good, but you may have to support with accommodative footwear also. Many ulcers, many forefoot ulcers, for example, ulcer at the 5th metatarsal head and 1st metatarsal head. The whole forefoot is in equinus. The culprit is TA. Whereas the picture I showed, the ulcer is there only on the 1st metatarsal head. It was peroneal overdrive.
I think you do pressure studies also.
Yes, sir. Yeah. We have foot scans which will tell you what happens. Then you have to see the gait analysis. You have to ask the patient to walk barefoot just like he walks. Whatever when you do ask him to do it, they'll keep the foot up ulcer consciously. That will give a wrong impression. Ask him to walk quickly for a long distance and you observe. Thank you very much.
One more point which I learned from Ajay Kumar sir's conference about the callosity excision. You have to drive with spirit, I think, not with beated. In that video, it was beated.
Yeah. Thank you. Thank
sir.
you for the
May-
nice interaction.
Yeah, thank you.
May I request Dr. Madhu Murali to kindly hand over a certificate to our esteemed speaker, Dr. Ajay Kumar, please. Thank you, sir. Thank you so much. May we invite Dr. Dilip Damodaran and the interim, an announcement for the PG students again, for attention of the PGs attending the hands-on session. Both these sessions will be held at 1:30 p.m. The USG sessions and Venus Doppler at 1:30. Both sessions, please. Over to you, sir.
Good afternoon, everyone. Let me thank the ASI and to giving me this opportunity. D2 gastrectomy or D2 lymphadenectomy in a gastrectomy was about 2 decades ago a procedure which was debated. There were a lot of debates on this between D1 and D2. Now, after 2 decades, a lot of literature has come and this has fairly become standard, and I'm sure everybody practices this procedure. So moving on to the video per se proper. We do a staging laparoscopy, ascertain there is no peritoneal disease and there are no other features of inoperability, and then we open, it's a midline laparotomy from xiphoid to just below the umbilicus. The ligamentum teres is taken down, we inspect the entire abdomen, make sure of the operability, and we start with the bursectomy. The bursectomy is actually separating the greater omentum between the third and the fourth layers and reaching up to the pancreas. There is now proof that bursectomy is not needed, but still bursectomy is performed because it helps in good D2 lymphadenectomy, especially over the vessels. So it's not an oncological necessity, but it's a technical necessity that we do a bursectomy. So we go, there's a vascular plane, you can see it's just coming out, and we continue it over the pancreas, the capsule of the anterior surface of the pancreas, and we reach up to the anterior border, the superior border of the pancreas. So as we proceed, we also go and take the station 6 nodes. The station 6 nodes are the subpyloric nodes. So this is, you can see slowly that tissue is getting separated, and so here the head of the pancreas starts appearing, and we have to actually clear all the head of the tissues over the head of the pancreas. And as we do, we will be ligating the right gastroepiploic vein and the vessels. So we continue this bursectomy so that we get all the tissues over it. The station 6 nodes are taken along with the specimen, and the vessels over there are very flimsy, so one has to be very careful, because if the assistant inadvertently puts a mop roughly, these vessels get torn. So one has to be very careful, and these tissues are all taken into the specimen. Here the right gastroepiploic vessels are ligated. Now we also come to the hepatoduodenal ligament. As a part of D2 lymphadenectomy, you remove the nodes in the 12A region. So here I am expose the tissues over the hepatoduodenal ligament, and then this has been brought down, and eventually we'll also ligate the right gastric artery and all the lymphatic tissues and the lymphonodular tissues along with it onto the specimen. So this helps in actually making a window along that is trans D1, and so that we can staple and divide or do the distal transection. So here we are past the stapler, and the distal transection is done. So following this, we start our D2 lymphadenectomy, that is removing all the nodes from the stations 7, 8, 9, 11, and exposing the hepatic artery proper. The hepatic artery is exposed, and then you go on to the coronary vein as well as the left gastric artery. So left gastric artery is then ligated and divided. And this tip to this is that always keep slight stump of left gastric, because if there is a hemorrhage later, the interventional radiologist can actually go in and put a coil or a glue into that. So this is one area which sometimes bleeds whenever there is a leak. So you always leave a small, you remove all the lymphatic tissue, but leave a small stump. And that is also, whenever you do a Whipple also, there is a tip that the gastroduodenal stump has to be kept slightly so that you can actually coil it later. So here sequentially the hepatic artery is exposed, and you remove the 8A as well as the 8P nodes which comes. The 8P is the posterior, the 8A is the anterior ones, and those lymphonodular tissues all are taken en bloc. And after the left gastric, then the celiac trunk is exposed, and then you move on to the splenic artery. The proximal splenic artery nodes are removed, that is the 11P, and so you don't have to go up to the splenic hilum in a distal gastric cancer. In a proximal gastric cancer, you will have to go up to the distal splenic artery. So there's the splenic the celiac axis is bad, and then you go to the station 1 and 3. There is a lesser curvature. All the lymphatic tissues and the has to be cleared. The entire lesser curvature has to be clear. So station 1 and station 3 are cleared. So once you clear the lesser curvature, then you are ready for your transection. The stomach is transected based on the histopathology. If it's a well-differentiated tumor, you need a 5 to 6 centimeter of proximal clearance. If it's a poorly differentiated cancer, take a larger one, 8 to 10 centimeter of distal clearance. So having transected, then you do your anastomosis, whichever way, it may be a Billroth 1 or even a Billroth 2 anastomosis is fine. It's very important to actually open the specimen in the greater curvature and harvest all the nodes and send it for histopathological examination. That will give you, the harvesting of nodes is very important, and that will give you a lot of data as well as increase the lymphatic yield. This again the similar case where after subtotal gastrectomy we are doing a lymphadenectomy. Just reiterating the whole things. One can do along with the specimen on block or under easier thing, maybe you remove the specimen and then do the lymphadenectomy. Here it has been done after removing the specimen. You remove, you start from the 8A and the 8P nodes, sequentially exposing the common hepatic, the proper hepatic artery, and the hepatic artery is exposed, and you also, that is by doing this, you also take the 8P nodes along with it. Here already the left gastric artery is ligated and divided along with the specimen. There will be a lot of small venous bleeds from this 8P region. So, and there are also a lot of lymphatics. Sometimes it is better you put clips and then remove it, or you should be very careful with the hemostasis and go meticulously around it. So here the hepatic artery is actually retracted and all those nodes are taken. In this point, sometimes even the portal vein gets exposed and all the tissues over it are removed along with it. So you can retract the hepatic artery and take all those 8P nodes. The energy devices have actually made things easier, because around about 2 decades ago, this procedure was considered was associated with a lot of morbidity, but now this is a routine procedure in most of the surgical as well as surgical oncology theater. You move on to the splenic artery. The proximal splenic artery is also exposed, and all the tissues are removed along with it. So this would be the final picture. You expose all the celiac axis, the hepatic artery, as well as the splenic artery, and the crus of the diaphragm, and all those tissues will automatically will get exposed, and that completes a good D2 lymphadenectomy. A D2 lymphadenectomy is good, especially in preventing the bed recurrences, and also the long-term results of the Dutch cancer, stomach cancer study has come, which has shown its benefit. I think that completes my video. And
thank you, Dilip. Very nice video. How many minimum number of nodes one should remove in D2? Usual PG question.
So you should have at least 15 to 17 nodes to qualify for a D2 lymphadenectomy.
We done 15. Okay, 16.
Just to answer that question, the basic numbers given in NCCN guidelines or any guidelines used to just to create the basic requirement. So if you go by Japanese poster, or if you do a good D2 dissection, and as Vipin was saying, if you dissect out the nodes and send it separately by your own side,
Harvesting
end
is
up
important.
having at least 25 to 30 nodes. In
Harvesting is very important in
So
this.
in the actual dissection, 10 nodes or a neck dissection, 6 nodes is the bare minimum. That doesn't mean that that should be the standard. It should be much, much higher than what you mentioned. And if you do it separately, you will get the numbers.
All this about D1 and D2 lymphadenectomy debates, everything was actually inspired by Professor Dayan Babu, sir, when we were postgraduates. So, and the debate still continues. I'm still surprised that debate still continues.
One question for sake of postgraduates. You never mentioned station 10. So what is the current consensus regarding station 10 removal or the splenic hilar node? Should that be removed or should it not be?
In a distal gastrectomy, distal tumor, I think you can actually leave it because you're not going there. But if it's a proximal gastric, then you remove the station 10 nodes.
I think 2022 updates of the Japanese guidelines says that even in a total gastrectomy, it need not be removed unless you
Yeah.
find them on
In the greater curvature.
Because why this station 10 becomes important is it was the one that was producing the mortality and morbidity. When you want to take out the station 10, you end up
And the
having a distal
splenectomy.
pancreatectomy or splenectomy, which was contributing to the mortality or morbidity in the studies. So if you can avoid taking that, you can avoid a splenectomy. So that's why the debate about station 10.
Now there is consensus, 10 need not be removed.
No.
Any questions from the floor? I think most of the postgraduates are out. Right.
Thank you, sir.
So thank you, Dilip.
May I request the chairpersons to kindly hand over a memento to our esteemed speaker. Request all of you to join in, please, sir. Thank you. Come to the end of the session. Thank you very much to the speakers and the chairpersons. Ladies and gentlemen, we break for lunch now. We'll commence exactly at 2:15. Request all of you to kindly be in the hall.